Indonesia and
Nagre-record niya
Vietnam.
ka. Pag nasa-save na to,
So
i-play
we
mo
will
ng add
start
sa
on
cloud sa
8 p.m. to
sa
10
drive.
p.m. in
Ayan.
Thailand
O, ayan,
Standard
nagre-record
Time.
na yan.
During the webinar has started, you can type a question on Q&A tab, and our speaker will answer before this webinar ends. Before we start, I would like to introduce our company first, a little bit. Awesome Korea has started from 1997, and Awesome Thailand started from 2006. Now, Awesome in Thailand has been working 17 years. On the screen now is a Bangkok Awesome Implant Symposium. Is a event of our Thailand, Awesome Thailand. So if you would like to need to more information, you can scan QR code on the screen now. Okay. Today is the first time of Southeast Asia Awesome webinar. The topic is contemporary guideline for implant placement and prosthetic, focusing on function, aesthetics, maintenance, and complication avoidance by our course director, Dr. David Chong. Dr. David Chong is the senior course director of the basic and advanced dental implant training course of AIC Education and has been a premier lecturer since 2007. He is regularly invited to lecture to dentists all over the world. Okay, so I would like to talk inside, okay? สวัสดีคุณหมอทุกท่านก่อนนะคะ อันนี้เราจัดเป็นเว็บวีนาออนไลน์ครั้งแรกนะคะ ก็เราในฐานะที่เป็น Awesome Thailand เราเป็นโฮสต์ที่จัดในการออนไลน์ในครั้งนี้แล้วก็ครั้งนี้เป็นครั้งแรกนะคะคุณหมอ ก็ถ้าเกิดมีตรงไหนติดขัดก็อาจจะเดี๋ยวว่ากันในครั้งต่อไปปรับปรุงในครั้งต่อไปนะคะในเบื้องต้นนะคะคุณหมอทุกท่านเราสามารถใช้ Q&A มันจะมีฟังก์ชัน Q&A ที่อยู่ในแถบด้านล่างคุณหมอสามารถกดตรง Q&A แล้วพิมพ์คำถามไว้แล้วเดี๋ยวสปีกเกอร์เราจะพิมพ์ตอบให้หลังก่อนที่จะจบเว็บบีน่านะคะก่อนจบช่วง15 นาทีสุดท้ายนะคะจะเป็นช่วงตอบคำถาม Q&A ให้นะคะโอเคก็ถ้าทุกท่านพร้อมแล้วเดี๋ยวขออนุญาตส่งต่อให้อาจารย์เดวิดชงเลยละกันนะคะโอเควันจังนี่ Are you ready?
Of course. Always.
Always. Okay.
Yeah, but please no recording today. Can you turn off this recording?
Yes. Okay.
Yeah, turn off the recording. Okay, it's really weird. Okay, please no more recording for this one. And you guys gotta promise me on that. Okay. Hi, it's my pleasure and honor to present my presentation for a South Pacific Asia webinar series, and it's more special because this is the first webinar series of South Pacific Asia. I think it's an opening door for a lot of people and a lot of dentists who cannot attend our offline courses. So I think that this online course will benefit you, and hopefully you will reach out to people who cannot listen and be able to join the seminar when I'm there or when anybody's there, that you'll be able to understand the lecture better if you get some kind of teaser. So they asked me to do a 6 series of teaser, and I agreed. And every month I'm going to do a seminar. The topic today is going to be the simplest topic today, where the ideal 3D implant placement, but you'll be very, very surprised because things change very fast in implant dentistry, just like a telephone. For example, 2G phone, who uses 2G phone? Everybody uses smartphone. Why does everybody use smartphone? Because we feel that it's better and technology is moving faster than us. That is why. And guess what? Implantology is faster than the smartphone. They have came a long way, and the design of the modern design of the implant that I'm going to discuss to place it into optimal condition and optimal placement and angulation, so that any prosthesis that you will do, will any impression you will do, will come up with a very good prosthesis. So I'm going to go a paradigm shift in implant dentistry. My introduction, I teach at 3 different universities, and one main being a New York University. I am much more involved right now. I'm about to open my own digital program in New York University very soon, and I have a big meeting tomorrow, and say good luck to me. So that's what I'm going to do. And I do teach for the University of Maryland, and I'm an adjunct professor at Guangxi Medical University, and so on. I've been with Hyosin for since the year 2007. So I've been actively teaching for this OSTEM company for about 17 years. I do a private practice. I have a private clinic that I used to have, that I had it for about 24 years. I've been placing implant about 24 years. Okay, so today we're going to talk about a simplified topic. I simplified the topic, a paradigm shift in implant dentistry. And I would like to thank my mentors and my friends for this presentation. Dr. Young Jin Kim, Chin Kim, Osan Yu, and this is actually the first live surgery that I did in Malaysia, and after the live surgery, after a first day implant course, there was no live surgery, but these 2 participants lived right next to where I lived. It was very close. They worked in right next to where I lived, and I was in the hospital. So I asked them, I agreed to help them out in their first live surgery, since they offered me something that I couldn't refuse. It was a lunch. So I said, okay, you buy me lunch, I help you. So I went to this clinic, and OSTEM Malaysia has set up a beautiful setting for this live surgery. And she never placed the implant before, but she had a sinus surgery. So I said, no problem. Using OSTEM cast kit, we were able to lift the sinus without a problem, as you can see. Beautiful, beautiful implant placement. Angulation is beautiful. Occlusion is perfect. And position, that you have so much bulk bone and palatal bone, and you even lift the sinus. This surgery is fantastic surgery, and this was the first time placer, and she was very, very happy with this. She was very, very happy with this. So that I really feel that this just exemplifies that if you get a proper education with a proper instructor and with an attitude that you want to serve the patient, I guarantee you that you're going to get the good result. It's all about a proper education and repeating same thing in your practice, while you're adding your knowledge, while you're going out there and learning from your mentors and your colleagues and your friends. So if you do that, your clinical practice will be somewhat stress-free, and at the same time, you will benefit from the optimization of your implant placement, because a patient do not feel any pain. This implant fixture will be able to stay in the patient's mouth for a long period of time. So let's do a top-down approach concept. The new concept is top-down. There's no doubt about it. There's no argument about it. It's top-down concept. The top-down concept means that you must imagine the restoration. So we have a defect in the anterior dentition right here, and a 1-2 and 1-3 area, and a horizontal and vertical deficiency seen from a impacted canine extraction. After. So you see a very much in defect, and this defect is not allowing us to place an implant in an ideal location. So we do need to build some with the hard tissue and possible soft tissue to maintain that implant placement for a long period of time. So these are the defects that you're seeing in quiet defect. Now let me introduce you to surgical stent. Why do you have a surgical stent right here if we're not going to even place an implant? Because we're going to imagine where the final restoration is, and place an implant in such that is an ideal location. If it's healed rich, it's maybe 4 millimeter. If it's a immediate, maybe it's a 5 millimeter. That really depends on a patient's condition. If you did an atraumatic extraction and everything's well, then maybe a between 4 to 5 millimeter is okay, but close to 4 millimeter. But if the site is an immediate site and if it's a very much of the you can see a lot of inflammation, it's not healed completely, then you're going to expect some type of a rich changes. So you might want to place a little bit deeper, closer to 5, so that you could compensate or you could compensate for you could compensate for the tissue shrinkage. So okay, so now we know the ideal place of dental implant. So we do need to know the surrounding of dental implant, so that we need to build the surrounding for that implant to stay for a long period of time. So therefore, now hard tissue augmentation was done with a non-resorbable membrane and you can see a pseudo-periosteum, but still we have enough a thickness of the ridge to place an ideal implant placement. So implant was placed ideally, and there was lack of a soft tissue. Therefore, we're going to try to build the soft tissue using VIPCT and a connective tissue graft. Don't worry, if you don't understand this, don't worry. We're going to go step by step by step by step, and by the time a sixth webinar, we might be able to understand a lot more. And then we're going to try to build the papilla with a VIPCT and try to build the thickness with connective tissue graft so that it doesn't come down. You must understand that you need to build a horizontal to keep the vertical. It goes same thing with a hard and soft tissue. So you need to have a vertical certain amount of the horizontal thickness of the hard tissue to keep the vertical thickness, or else vertical thickness start to go down. Same thing with soft tissue. You need to have a horizontal soft tissue so that you could prevent a vertical soft tissue going down. So now, as you can see, and we're going to try to bulk up the horizontal tissue, soft tissue, so that a vertical soft tissue remain still. And therefore, you can see a very nice healing with a provisional. And after a final impression, you could get a final restoration that is an exact replica of what we planned about a year ago. So as you can see, a beautiful, beautiful transition between what we planned and what we got at the end. And this is what we're aiming for. So we have to always aim for the final restoration and where to place the implant and such so that you can plan for a better implant placement. And if you do not have enough hard and soft tissue, you're thinking about either compromising your placement or build the hard and soft tissue so you can place the implant in an ideal location. Now, case looks fantastic, but how do I get there? What do I need to understand to do all this? Because this procedure does not come in one shot. If you're a beginner and try to get this procedure, I say good luck, because I don't think you can get it. You need 8 years of experience to do that with the right knowledge. When you have once you set up the right knowledge, then you just need to add on the information every time a year passes by. But when you have the wrong knowledge to start with, it's like buttoning up your wrong buttoning up your wrong press button. When press button is wrong, every button will get wrong. So you need to understand something, and what do you need to understand? Therefore, I want you to understand the current concept of the ideal three-dimensional implant placement, as well as the current concept of the implant prosthesis. So let's talk about ideal placement that leads to implant prosthesis, and we're going to talk about the current concept of the short implant to avoid such a trouble such as guided bone regeneration, because there are a few ways to avoid the guided bone regeneration, and we're going to talk about it in the 5th lecture. It's going to be very, very exciting. It feels like I'm giving all my knowledge out throughout this 6th webinar, because the 6th webinar lecture is the lectures that I usually do in other countries and big conferences. So you will definitely benefit from this webinar if you understand. But of course, seeing in person just makes it much better. So I hope to see you in person. But before that, I want you to understand. I want you to understand in my lecture and other people's lecture by looking at these type of seminars and prepare your knowledge before you go into the conferences. So let's talk about a 3D implant position. Everybody talks about a hard and soft tissue and sinus and all that, but if you don't know how to place 3D implant position, the patient's not going to receive an optimal treatment because their prosthesis will be wrong. So now, when you look at this ideal 3D implant position, all the good things will happen, including minimize biomechanical problem, maximize aesthetic. It's not a prosthetic problem when you have a constant screw loosening or abutment fracture, and it leads to fixture fracture because many people think it's prosthetic problem. It's actually the implant placement problem, and I'm going to talk about that. It actually maximizes aesthetics when you place in 3D ideal implant position, and a less fluid impaction create proper emergence profile, creates environment for better implant maintenance, and which is very critical, and easy for lab to fabricate prosthesis, therefore less implant complication and high implant success rate, and easier to maintain. Now, you see this type of cases all the time, and you might blame the implant company, you might blame the lab, you might blame someone else. But it's actually the human factor that resulting in errors of judgment. Someone else might be the right answer, but more importantly, I think it might be you. You might be causing this. Clinician is the main cause of the implant complication and the biggest risk factor for the patient. And this study was revisited. This study was first introduced in the year 2000, where you see an abundance of the implant complication and aesthetic complications seen in the anterior. Now we have gone a very far, 24 years far, as developing a good technique for anterior, but it's getting revisited because main cause is the clinician, and more clinicians right now tackling dental implants with money. They think that it's only money, but there are a specific way to treat this to maximize and optimize the treatment outcome. So we want to place an ideal implant treatment planning. In year 2023, which was last year, in European Congress of Academia of Osseointegration, they really emphasize some of the factors that considers a anterior implant treatment. But anterior implant treatment deals with the ideal implant placement. It's very, very similar to any other treatment. Any other area is a little bit more generous than anterior implant treatment. So when you could do an anterior implant treatment, you could probably do every other area in the mouth. Now, for the anterior treatment, 3D implant position is crucial. And of course, sufficient bones, soft tissue thickness. Therefore, you get good emergence profile, and it's for the best aesthetics. You might want to apply a provisional restoration. Now, if you think about all this print factors, if you place a ideal 3D implant position as such, then you could get a sufficient bone and soft tissue and allow a good emergence profile with good profile. You just need a provisional with a ideal 3D implant position to get a good aesthetic anterior implant placement. Simple as that. So I feel that among all these factors, there are no more important than the other, but ideal three-dimensional implant position really pops up to my eyes. Because I'm so sorry about this. What's going on? Oh, okay. I'm so sorry about this. I must made some kind of mistake on the I made some type of mistake on my yeah, I wrote it twice. Sorry about that. Sorry about that. So I was like revising my lecture yesterday, and maybe something. Okay, sorry. So what is the dealing with ID 3D implant position? ID 3D implant position such as this is an older case, and when you look at ID 3D implant position, this was placed with free hand, and ideally it was a mesiodistally and buccal-palatally, as you can see, and apical-coronally. This is ideal as you could get in that era. So wow, look at the wonderful implant placement towards the palatal, as you can see. Now there's something called comfort zone and danger zone. So when you place an implant mesiodistally in this green zone, it's a comfort zone. But when you go too closer to the dentition, we call that a danger zone, and there's going to be a bone loss around between implant and natural dentition. Apical coronally, also there is a comfort zone. For me, I think apical coronal is very crucial for a profile of dental implants, for prosthesis. So if you place it too deep, it might be a hygienic problem. But if you place too shallow, everything will go wrong, instead including aesthetics. So you do need to place an ideal. What's that ideal? We're looking at around 45 millimeter, and we're going to talk about it in detail very soon. With an angulation, if you place an implant like this, it's going to be cementable. It's going to be very good. But if you could place it this way, towards the cingulum, you're going to have a better response, tissue response with hard and soft tissue. And also, it's going to look a much better in aesthetic and maintain for a longer period of time because of the increased dimension of the gap between the buccal plate and a implant fixture. But if you do place in this red line, you're going to expect some type of a wrong aesthetic and wrong maintenance, and maybe not going to generate enough a hard and soft tissue to do this. So this is going to be an aesthetic nightmare as well as maintenance nightmare. So just by changing small angulation, a detrimental effect could come like this. So as you can see, when it's ideal, it's a beautiful restoration, and not even a crown was done in a contralateral a tooth like this in A1 or 2-1. You see a beautiful restoration, but someone might say, what about here, Dr. Chan? And you might have a problem with the papilla. Then what do you say? I tell them to wait, because a papilla-wise, the 90% are not perfect papilla at the time, most of the time, according to 1997. Right now it's a little bit different. You can maintain the papilla, but this is the general idea. After 1.5 years later, 80% increase in papillary volume and 60% shows the perfect papilla. So, what's the remedy? Remedy is time. So you just need to wait time if you did everything perfect, because the literature don't lie and the statistic of the science don't lie. So right here, you can see at the 6-month post-op, a crown insertion, you can see a beautiful papillary growth, which could show a nice scallopness of the pink gingiva, which is the true aesthetic. And also 4 years and 3 months post-op, you can still see a maintenance of the papilla right here. And how can this be? Is this magic? This is not really magic. This is only for study. This is not magical. We're measuring a distance between the top interproximal bone to the inferior portion of the contact. And when you see this type, when you have less than a 4.5 between implant and the tooth, the study shows that you're going to get 100% papillae. If you have more than 4.5, the percentage decreased by a logarithmic curve. So maybe it's like okay, you're going to get, if you go 5 millimeter, you get 98%. If you go like maybe a 7 millimeter, you get like 20% or something like that. But in order to guarantee 100% papillae, you could control the distance. Is there a guarantee in implant dentistry? There are such a guarantee in science too. The fundamental science do not change. The technique changes that you need to keep up, but the fundamental of the science do not change. So if you place implant like that, and as you could see, no magic here, then only science is effective here, then you could get a wonderful result clinically. Now, relevant to that, when you see a labeled empty, a papilla right here, and it might be that a distance might be longer than a 4.5 millimeter, as you can see, 5.9 and a 5.0 correspondingly. But if you can see a perfect papilla right here, the patient is very satisfied, and I could guarantee you that this is a 3.5 and 4.1, which is less than 4.5, that guarantees 100% papilla. So if you know this formula, that apply the science and to make your case a much more aesthetic and functional is a totally possible. So therefore, how do you plan this? Even though you do a lot of guy surgery, you need to know how to plan it. And especially if you're not doing a guy surgery, and if you're doing a freehand, you still need to know what's going on with the surrounding. It's not just the putting on the screw into the bone. If it's easy like that and making that much money, everybody will be a dentist and implantologist. But it's not true. If you speak to a very experienced implant people, and they'll tell you, if they did it right over the years, they'll tell you that tissue response over the years is very important. Tissue response means that how does a periodontium around the implant will respond over the years among all this irritation from the oral cavity and plaque and calculus formation. How do they resist all that? So we're going to talk about a guideline for 3D implant placement, which it talks about the surrounding of the implant, which make us to keep, which allow us to keep that implant into patient mouth for a long period of time, so that patient do not have to worry about it. Only thing that you need to worry about is just the patient's maintenance part. That's about it. So let's talk about a guideline for 3D implant placement. And this should be one of the first lecture and one of the entrance lecture. But let me tell you, those of you who place a couple of thousand implant, if you listen to this and if you find something new, I wouldn't be surprised because I'm talking about the current and contemporary thoughts. By the way, my lecture is different every year, every month, because my thinking changes and technology changes. So I like to follow it up, but my fundamentals do not change. But my thinking changes according to the science and technological changes. So hopefully I do not get recorded and you get to listen over and over and over the period and continue to educate yourself to be an updated dentist. So let's go with the updated a guideline for 3D implant placement. So now we're thinking prosthetically driven implant placement. But right now, if you're talking about the top of the line, we're talking about the facially driven implant placement with a facial scan, that a facial scanner that could even get you to get an easy midline and all that. Okay. But if you don't have that, especially South Pacific Asia, what I noticed is that there's a little bit less distribution of the CBCT in digital, but I guarantee you it's going to blow up. So maybe you could be the first one, or you could be the one of the few frontiers could conquer the digital. And in order to start the digital, you must know how to place implant precisely, so you could plan it precisely. So it should be a prosthetic-driven implant placement or facial-driven implant placement. And if it's in the molar, you place in the center of the restoration. If it's towards the incisor, then you want to place it, if you can, towards the cingulum, so that you could use a cement-free, as well as you get a better, a softened, a hard tissue response. So top-down implant restoration really means that you must imagine the final restoration, just like I showed you. And if you can place an ideal implant placement and have the surrounding, that's fantastic. If you don't, you might want to change the implant position or do a guided bone regeneration or soft tissue augmentation to create a proper surrounding for that implant fixture to stay there for a long period of time. So we want to have some type of guaranteed long-term success. So in order to do that, you must get the axis of the screw hole correctly. And axis of the screw hole for the molar is right on center of the restoration, as you can see. And for the anterior is towards the cingulum. If you keep this formula and try to do this, even though you might not be able to, then you're going towards the fine line, because you're going to be a better implantologist. For mesial distal position, I feel that being the center of the restoration is the most important position out of all. Out of all, mesial distal position is I feel that most important position to represent the center of the restoration. Of course, everything else is important, but mesial distal position really dictates what a patient is going to use and how comfortably patient is going to be using that restoration for a long period of time. Apical coronal, labial palatal, and implant angulation that we're going to talk about. So, for mesial distal position, we want the implant fixture to represent the center of the restoration. And if you don't, you might get a severe cantilever. And we call that a bending moment. And bending moment, if you get some type of cantilever like that, and 4 millimeter to 6 millimeter, and applying a 250 Newton centimeter and offload showed us that a moment decrease in 34%. That's a lot of torque. That's a lot of torque. So we're going to try to minimize any type of cantilever to make sure that we don't get a bending moments like this. Now, if you look at these two cases and these two implant without the restoration, this two implant placement looks identical and looks very, very good. But if you actually look at it, as this to the left side is implant success and aesthetic success, and then right side is implant success. But this is aesthetic failure. Let me tell you, this is an aesthetic nightmare to place anything like this in between a embrasure, not representing the center of the restoration mesial distal. It's a nightmare to place anything implant like this. So aesthetically. And is it okay all on 4, all on 6? You must understand the prosthetics. Is it FP1? Is it FP1? FP1. Or is it FP2? Or is it FP3? FP1 is a normal restoration in the normal size. FP2 is a little bit longer dentition. FP3 is one with the gingiva. So right now, FP3 is becoming really, really popular because it's easier in my personal thinking. But you must understand, FP3, you have to destroy all the bone to get the ridge. So I like to keep the FP1, FP2 if it's possible. And for FP1, FP2, a mesial distal position for implant fixture being center of the restoration is very crucial. Now, you must understand what causes a crystal bone loss. Crystal bone loss is caused by a micro motion. Micro motion. So micro oscillation. So micro movement causes a bone loss, not micro gap. Micro gap might lead to micro motion, but a micro gap is not a cause of the crystal bone loss. It's micro motion. So every time there's a joint like this, there's going to be an oscillation, oscillation, oscillation like that, oscillation. And if it's included in this oscillation, you're going to get a bone loss. Oscillation comes from horizontal factor and vertical factor. So we're going to talk about a horizontal factor of the oscillation. And this is almost equal to biological width because this implant and this prosthetic will have an oscillation like that, oscillation, oscillation. And among this oscillation, and we need to see how much is the horizontal horizontal factor of the oscillation and how much is the vertical factor of the oscillation. So horizontal factor of the oscillation is giving us about 1.5 millimeter. When implant to a natural dentition, if it's closer than 1.5 millimeter, it might cause a bone loss. But that's why it has to be greater than 1.5 millimeter. Greater than 1.5 millimeter means that it's greater than 1.5 millimeter, not ideal. 1.5 millimeter is not ideal distance. You need to have a greater than 1.5. I like to be around 2 millimeter if it's possible. So when 1.5 adds up with another 1.5, between implant to implant, you should have a greater than 3 millimeter. Like I said again, 3 millimeter should not be an optimal. It should be greater than 3 millimeter. So it could be 4 or 5 millimeter and it should be okay. As long as it's greater, you don't lose bone. And one of the factor to make you understand is a saucerization. I already told you that between the implant and the abutment interface, there's going to be a oscillation like that. Okay, when there's an oscillation, there's going to be a bone loss due to micromotion. I told you micromotion causes crystal bone loss. We call this a saucerization. So when you see a two saucerization made from a two separate implant and two separate implants are away together and greater than a 3 millimeter, and you see an inter-implant bone has a rise like this and you don't have any bone loss, therefore the soft tissue might follow a bony contour. So this is a fantastic case. But however, Dr. Carl Misch actually took a look at 1997. He took a look at when implants becoming too close together and they start to lose the bone. Why? Because he realized that this saucerization has been overlapped. This oscillation has been overlapped to cause this bone loss. And Dr. Dennis Carnell in 2000 perfected this research by measuring them, and a measurement came from there, 3 millimeter and 1.5 millimeter. So this oscillation, the saucerization that we need to recognize, and we need to put the implant a little bit further away from each other or further away from the natural dentition. Also, we want to calculate after the mesial distal position is complete. Now you want to make sure that you get a good apical coronal position. Apical coronal position determines many different things, and a biological width plus the shape of the emergence profile and emergence angle. So apical coronal position, I do have a lot of things to talk about, and it has changed over the years quite a lot. So many people, if you don't understand my lecture about apical coronal position, then you must look at current literature. The old literature says something else because they're using different design of an implant. But if you're using the current literature, they're using the conical ceiling and internal hex and bone level type of an implant. If you're using an internal hex bone level conical ceiling where it's been used, using in the year 2024 abundantly, and so many usage of that in every different company, and right now this is by far the most popular design of dental implant, then you must understand how to place this implant. So if you're using other type, then you need to learn how to maximize and optimize a placement for that implant fixture. But if you're placing implant fixture something like this design, like a rock solid BLT, BLX, Straumann, Hyosin ET3, Ostem TS4, TS3, very similar design, then you must understand. So apical corner position right now and currently is a deeper the better, but not as deep. So that's a very tricky. So let's talk about that. So if you're confident that you're not going to cause any bone loss and everything, then we go around 4 millimeter. But in immediate cases, or when soft and hard tissue is a little bit more inflamed, and I expect more changes in hard and soft tissue that I mentioned after I place an implant, so I'm going to overcompensate that by placing it a little bit deeper so that if I do lose 1 millimeter of the bone, I still be okay with 4 millimeter. So if that's my thinking, then if I don't get any bone loss, still I have a 5 millimeter. 1 millimeter a little bit deeper does not cause an implant failure. It's a safety margin. So my suggestion, when in doubt, then just sink your implant a little bit deeper to avoid the GBR possibly at the same time for a better profile of your final prosthesis. Around 4 to 5, as shallow as possible, as deep as necessary, and you'll realize as you get better and better in implantology, you'll place implant a little bit in an ideal placement and possibly grafting and all that. But if you're still a beginner, maybe a deeper implant placement is suggested. So when you place an implant like this in the interior, it's a blessing to cross a transition zone. We need to make this transition zone to a soft tissue architect. We need to shape the soft tissue a certain way so we could get a gingival harmony with adjacent dentition as well as a better profile. So the bone level implant that we're placing actually is wonderful for creating this transition zone. This transition zone needs to have certain length, and also this transition zone is a very crucial zone for a initial protection of the implant fixture with the bony interface, which means there are you might think that there is pocket depth. So you think that there is a pocket depth, and using a perio probe, you're doing all the way to the pocket. This is not true. It's not true at all. It's not true. Many people think it's true. It's not true. Many people think that long neck implant has a deep pocket. It's not true. So let me tell you why it's not true. Because underneath there's something called adherent zone. Among the adherent zone, there's connective tissue zone and junction epithelium zone, and also plaque zone. So plaque zone right here do not bind to the abutment, but a junction epithelium zone and CT zone, connective zone, binds with the abutment when the abutment is nicely bacteria-free and clean. That is why what I do is that whenever I remove the healing abutment or the abutment, I drip in the chlorhexidine, and I don't suction out the chlorhexidine. I leave it to kill the bacteria, and I wipe the abutment with the alcohol so that it's bacteria-free, and insert that abutment into this transition zone so that I could facilitate the attachment of the connective tissue and junction epithelium. So if you're measuring the pocket and socket, it's up to right here only, sulcular epithelium. It does not go deep. If you go in deep, patient will feel pain and you'll see bleeding because you just disconnected junction epithelium from the abutment. So this is the initial soft tissue attachment that protects underlying structure from a plaque and a possible calculus formation. Now, when you're placing an implant, then you need to understand the different mechanisms. If you're using an external hex, and all the occlusal load goes here, and if you're using a tissue level, this is where the interface is, where the abutment and the implant meets. And where the abutment and implant meets is actually subcrestal on a internal hex bone level implant, and this is what we're using. And this is an ideal because it shares the load with the bone. Implant fixture shares the load with the bone the best because the subcrestal placement of the abutment and a implant interface. But however, this is the best to share it with the bone. Bone gets really, really hard around the implant very fast because implant shares the occlusal force with the bone together. So this is the true a bone level implant. But however, when you see this section right here where the abdomen is entering the implant fixture inside is very, very thin. So if you look at this, external hex has a ferrule where when we do a crown prep, when we do ferrule to prevent all this inavariant fracture. But the internal hex do not have ferrule, do not have ferrule. So it must share the bone. It must share the occlusal force with the bone, or else it has chance to break. It must share the load with the bones, or else it has chance to break. I said it twice. It's so important. Therefore, it is crucial right now in year 2024 to sink that implant subcrestally by a certain amount to make sure that this implant fixture is sharing the load with the bone together. So now once you look at the von Mises stress is a stress between two matters, and we're measuring von Mises stress around dental implant. And when you look at the von Mises stress is concentrated in the crestal area. Whether or not this implant length could be 20 or 50, von Mises stress is concentrated in the crestal area, not on the apical area. So what do you think? We're going to lecture a little bit later regarding the short implant. What do you think? Which one is more important, length or width? If anybody tells you to place a 13 to 15 millimeter implant in the molar, then you think again, unless you're doing immediate loading, because that might not be necessary. You might do things that might not be necessary. Maybe you have a 2-chair office, but the compressor is for 200 chair possibly. Yes, it is good, but you overdid it. But in order to overdid it, you have to spend a lot of money. That's a side effect. To overdo the length, you need to risk a lot of anatomical structure being damaged. That's a risk. That's overdoing it. That's a side effect about overdoing it. So you need to do it adequately, and we're going to talk about that at the end of the lecture today. But as you can see right here, a stress distribution is concentrated in the crestal, and it is greatest right by the crestal. And it gets lesser and lesser as it gets deeper and deeper and deeper. So when you see a 3.5 millimeter diameter fixture stress analysis, if it's within the bone like this, embedded in the bone, it's really not much of the stress, but still stress is concentrated in the crestal, not much on the apical. But as you can see, a 2 millimeter bone resorption, and this area is not getting supported by any surrounding bone. Therefore, the stress distribution is the greatest at the tip, and you can see a amount of the stress. The amplitude of the stress is so great that it might cause a fracture. As the diameter increases, that if you increase the diameter of the fixture, the stress becomes less and less. Therefore, diameter choice is so crucial in deciding where you place an implant to withstand the occlusal pressure. That is why for the molar we want to have a greater than 4.5, and for the premolar we want to have a greater than 4.0, and such. Not just for the aesthetic, for of course the biomechanics as well. So now we understand if this implant fixture do not get supported by the bone, then it's going to lose bone. And there are a lot of situations that you do not have a bone support at the crestal level, possibly due to bone resorption, which is caused by you probably, or possibly a premature apical fixation, which means that you did not place it all the way. Now, what happens if you start to get a bone loss? This is a very important concept for me, because many people think that peri-implantitis is the cause of the implant failure. I don't think so. I do not think so. Peri-implantitis for me is just the process and the result of the implant failure. Why do I think that way? Because peri-implantitis usually occurs at the rough surface. So, if we create a surrounding so that no rough surface is being exposed, then I say we could prevent the peri-implantitis. And one of the most important things to prevent the peri-implantitis is the perimucosal sealing. That tells me that perimucosal sealing is the most important thing for to maintain the implant. Wow. Of course, in order to have a good perimucosal sealing, you need a support of the hard and soft tissue. But initial perimucosal sealing, initially, if you stop that hard tissue from exposing that rough surface, then you could really reduce a frequency of the periimplantitis and implant loss. So by placing implant a little bit deeper to the subcrestally may give you a better opportunity, in which I'm going to talk about. And of course, not exposing the rough surface will give you a much less chance of the future developing of the periimplantitis, because as soon as the rough surface develops and maybe a perimucosal seal breaks at the time of the patient when they do not have a great immune system, such as maybe patient has a cold, then all this plaque and calculus will bind, and it's going to cause a further bone loss due to periimplantitis. And when there's further bone loss, there's no support around the implant with the bone together. So although occlusal forces are beating the implant fixture alone, it could cause an implant fixture fracture and even further bone loss biomechanically. So this is just the bad cycle when you first expose your one rough surface. So my goal is not to expose that first rough surface, and that's my goal. So now for apical coronal position of dental implant, I really like to submerge at least 1 millimeter crestally, but 1 millimeter in every condition is not the answer. Sometimes in a very thin soft tissue, you need to sink it deeper, and I'm going to talk about that. But in generally, when you have a thick soft tissue, then I like to place an implant. Almost every implant placement is subcrestally like this, not equicrestal. Many people think that this is the true bone level implant. This might not. This has so much minus, and the screen circle is what I want to. I used to place implant like right on the middle, and I found a lot of different things, including a wrong emergence profile. So learn to place the implant a little bit deeper. And if you look at my old cases and my deeply placed implant that's been 17 years, not 18, 17 years, 16 years, they stay for the longest period of time. But if you do place superficially, it's not good biologically because you're already exposing your implant fixture rough surface. It's not good biomechanically because this area is not being supported with the bone together, so it's much easier, prone to fracture. And prone to fracture indeed, because the top neck portion of the conical sealing implant are the thinnest implant that you can see among all the implant structures. That's why I like to sink it at least 1 millimeter deep inside to make sure that I have a more bone marrow and more blood supply to support a surrounding soft tissue, as well as a more supracrestal attachment, more surface area for supracrestal attachment to stabilize this perimucosal sealing that prevents a initial blockage from anything from oral cavity. So I feel that this is one of the most important things, and let me emphasize this. Not just placing implant ideally, but recognizing the biology and recognizing the biomechanics of dental implants and the bone together, and placing such that this implant will last you forever, literally. So as you could see right here, and it's a bit, you know what? This 3D, conical sealing implant is beautiful. It's beautiful in a way that you don't have a gap. It's beautiful. So micromotion is really being minimized. So there is not much bone loss, and also a platform switching that we're going to talk about very soon. Minimizes bone loss. This is a beautiful, beautiful design. However, you can see that the red arrow area is the thinnest. Because that the abutment has to go into the internal portion of the cylinder, we call it internal hex. The abutment is the thinnest, as you can see. So when thinnest abutment is there, and a maybe lateral long restoration, maybe lateral force will occur, and it might be prone to fracture like this. So improper installation duct and could cause a crestal bone loss, or also a improper creation of the surrounding could cause a crestal bone loss, could lead to an implant fracture later on in the portion where the thinnest portions is. So when you want to place an implant with the internal hex in bone level conical sealing, which is the favorite implant of all time in year 2024, you must have consideration. So if you look at something like this, and patient is having one edentulous on the posterior mandible on the right side and placing it very superficially like this, for example, with a little bit wrong biomechanic, and you can start to see a biological width violation, and then maybe some bone loss like this, and this bone loss will lead to possibly a too much stress in the neck of dental implant because it's not getting supported by anything. So now it's not just a biological problem, it leads to a biomechanical problem that leads to a biological problem. Biomechanical fracture like this is almost equal to a vertical A fracture, the natural dentition. You can melt out the bone, hard tissue like there's no tomorrow. So fast, so fast. So early detection and early removal of this broken fixture is absolutely necessary. And as you can see, many things can happen in this type of an implant design. But these are the implant design that's going to this lasting for a long period of time unless other design comes. And this is a beautiful, beautiful design and used by many different companies. So I love it. So if I like the fixture with the internal conical connection, then I should really place them with a certain consideration. So what are the consideration? Consideration factor for implant depth control is a occlusal clearance, emergence profile, and their gingival thickness. So how does they matter? Now I already told you the ideal is an internal hex implant to place it subcrestally by 1 millimeter is a general rule. This is the general rule. Now, if you do not have enough space, what do? I used to place an implant very, very simple, just on the bone level like that. And guess what my prosthesis is going to be after 3 months later, after implant osseointegrates. Sometimes I don't have a room, so I'm forced to do this boat-like restoration with the screw type. Patient is chewing, and I thought that I was serving the patient very well. But what I realized is that when you place implant a little bit deeper, simply, you're going to gain that area of the soft tissue. The hard tissue is going to change to soft tissue zone. So I could increase the interocclusal space, and if I do increase the interocclusal space, now I have a more option for my prosthetic instead of just a screw type. So this is another apical coronal depth consideration. And you could, if you want to do an alveoloplasty, I don't want you to do a flat. I want you to do it something like this, so that you have an implant bone and soft tissue follow the contour. Okay, if you don't have enough room, then what do? If you don't have enough room, maybe place the implant deep and ameloplasty. You mix and match some of the modality of the treatment to make sure that you could have a more implant prosthetic option. If you have a good enough space, you will still place implant subcrestally. So now when you see this, how much room does each prosthesis need? So vertical biological width we haven't really talked about yet, which we're going to talk about, and you'll realize that we're going to need a 4 millimeter at least in being a soft tissue height. And we need in order to get any type of cementable, which we're not going to aim for, but we need a 4 millimeter abutment height as a retention base. And also 2 millimeter the clearance. So you want to have a 10 millimeter of the clearance. Therefore, if you engage a 7 millimeter healing abutment, such as 607 healing abutment, 6 millimeter diameter and 7 millimeter in height, you better have at least a 3 millimeter the clearance from opposing dentition, or else you need to place implant deeper, or do more enameloplasty, or a alveoloplasty, or maybe a root canal in the crown in opposing dentition to increase the room to make sure that you get a better profile. It's not just the screw type or cementable type. If you don't have a room, you're forced to have a very, very bad emergence angle and very bad profile, and underneath the soft tissue really might be inflamed, and therefore there's going to be a bone loss in final return and the results. So you want to keep that a good interocclusal clearance. To get that good emergence profile, we're looking for some type of an S shape. So S-shaped profile. We want to have a wonderful S-shaped profile to make sure that we get as natural contour as possible for aesthetically and functionally and for their future maintenance. In order to get this S shape, you need to control your apical coronal a little bit deeper, so you'll come out straight and then concave and then convex to do that. And if you really want to think about this prosthetic option I'm going to talk about later, what kind of angulation would be the best angulation, but you're not going to get an acute angulation with the shallow placement. You will only get the acute angulation with a little bit deeper placement. So if you still think that a natural tooth is like this and a implant should be placed right at the CEJ, you're very, very wrong, because a constituent of the implant periodontium is different than a natural dentition. Now, as you can see, if you place the implant a little bit too shallow, you can see the emergence angle is getting wider and wider. Whereas if you place the implant a more accurately into a considering the surrounding, then you can see that a 15 to 20 degrees, this is just an example, but in natural dentition, say emergence angulation, there's no less than 25 degrees that gives you that a less angulation, that a no is, if you look at the a natural teeth angulation, is no less than a 25 degrees. No, I said no more than 25 degrees. So it's always less than 25 degrees if you look at the interproximal emergence angle. And if we could replicate that in patient's mouth, then a patient's going to feel very natural. At the same time, patient's going to have a easier way to clean and for maintenance. Now, we spoke about the horizontal biological width. Now, let's talk about the vertical. I already told you, if there's an oscillation, there's horizontal component, there's also vertical component. And vertical component is, it's been a very known recently, but it's been around for a long period of time. And if you violate the vertical component, that means you're going to automatically have a rough surface exposed. So that vertical component, probably a number one criteria of a implant placement. You can place a good implant on everything, but in order for implant to survive for any time, long period of time, and do not have initial bone loss, then vertical zone component need to be really well practiced. It was first seen in 1991 by Dr. Berglund. He saw a natural biological width of natural dentition, and he compared to biological width of a dental implant. Because dental implant shares a different surrounding with the natural dentition and a weaker protection against natural than a natural dentition's attachment apparatus, so therefore we do need a bigger zone. So for epithelial attachment, we need 2 millimeter to protect, whereas natural tooth, you only need 1 millimeter. For connective tissue, you need 1 to 1.5, where natural tooth needs about 1 millimeter. So it's about natural tooth, biological width is 2 millimeter, and natural implant biological width is about 3 to 3.5 millimeter. So we need a thicker and more soft tissue. Therefore, implant needs to go in deeper into the apical clonal position. Well, if you look at this research data, you can see that a difference between a natural dentition and a dental implants. Now, this is a very convincing research by Dr. Vervaeke. I really like this research by Dr. Vervaeke. Influence of the initial soft tissue thickness on a peri-implant bone remodeling. So when patient had less than a 2 millimeter gingival thickness, then I realized that bone resorption occurred to a 1.23, so increase in soft tissue dimension by 1.23 millimeter. When it was 2 millimeter, in total, it became 1.03 in 2 years. 3 millimeter, 0.41. 4 millimeter, 0 changes. So now let's do an addition. Less than 2 plus 1.23 equals to 3 point something. 2 plus a 1.23 equal to 3 point something. 3 plus a 3.41 equal to 3 point something. So this is all telling me that if you do not have a greater than 4 millimeter the gingiva, body will reestablish the hard tissue to change into a soft tissue to increase the zone of the soft tissue so that underneath the implant in the bone will get properly protected. And this is the minimum requirement around dental implant of the soft tissue. This is what we call reestablishment of the soft tissue, because body is changing the hard tissue into the soft tissue. So thin soft tissue causes the reestablishment of the biological width. So when you have a thicker soft tissue like this, 4 millimeter and 2 millimeter in one patient, now after a certain time, 3 months, 4 months, 6 months, you see that where the soft tissue was 4 millimeter thick, it remains still. Where the 2 millimeter soft tissue has lost the bone, up to close to a biological width amount, which is 3 plus a change millimeter. So my aim is to get a 4 millimeter of the soft tissue from the beginning, and if I do not have a 4 millimeter, I'm going to sink my implant subcrustally so that I expect and anticipate the changes of the hard tissue bone loss to gain that soft tissue. And that's what I'm going to do. So therefore, if I see something like this, then I could assume or conclude that this bone loss has occurred due to the biological width. So now this bone loss could occur due to 3 different phenomena. Now, you can see a soft tissue thickness, and from here it's not 4 millimeter. From here to here it's not 4 millimeter. From here to here is 4 millimeter, and body reestablished the biological width by losing the bone to increase the soft tissue. Also, due to a shallow implant placement, this abutment angulation has been too obtuse, so that there's a greater abutment angulation, which could cause a soft tissue inflammation. In turn, could cause the bone loss. Also, if you split those two implants together, these 2 implants should be in same level, or else the usually high implant A position start to lose the bone to the lower implant level, or maybe just the deeply placed implant has a better stability. So as you could see, comparison between 2 implants, that one implant stays still and do not have any rough surface being exposed, but shallow placed implant has a rough surface being exposed, and this is going to be it's going to cause a further risk for this implant fixture to process of the periimplantitis. So we need to have a long neck, and we really need to have a long neck, and we want to not lose any bone from the beginning, and this is going to be my SOAR core formula of the 3D implant placement. So, as you see, apical corneal position consideration, biological width to me is the protection zone that is greater than 3 millimeter. And so therefore, my goal is to make the soft tissue thickness that's greater than 4 millimeter, and that's what I want to do. From the beginning, if I don't lose any bone, then I'm going to decrease the risk of the process of the periimplantitis. Therefore, patient can keep their implant in their mouth for a long period of time. So do not lose the bone from the beginning. And if you want to do that, you could place implant deeper, or have a thicker soft tissue to place. And of course, it's better not to lose the bone from the beginning. Let me emphasize. So one of the tricks is that when you have a greater than 3 millimeter of the soft tissue, and if the implant placed in such, then such is not really a problem. You got a 1 millimeter subcostal, soft tissue is 3 millimeter, not much is going to change, and later on it's just going to change like that, and you're going to have a beautiful, beautiful contour of the restoration like that, and now you're going to build a beautiful restoration like this. So now this is fantastic. But if you have a thin soft tissue like a posterior mandible, then you need to sink that implant down. If you don't sink that implant down, then you're going to be in trouble, because you're going to start to lose the bone, because the body is going to reestablish the biological width just like you saw. So you want to maybe sink it down a little bit deeper to make sure that all this area from here is a soft tissue, and length is about a 3 millimeter plus, I would say 4 millimeter ideally, so that I could still get a wonderful profile restoration. Okay, long neck, long neck, long neck, guys. We want the long neck restoration, guys. Okay, longer neck. So now, if you're a Hyosin user, Hyosin made it very simple and convenient. One thing that I am very pleased with OSTEM and Hyosin is the simplicity and innovation. They keep on innovating their stuff, as well as they do to make it simple. Only a genius can make things simple. Fools make things complicated. So now, I'm going to utilize their everyday components called fixture mount and dehealing abutment to control the apical corneal position. For fixture mount, it's fantastic because this fixture mount has a measurement. So you can see 1 millimeter, 2 millimeter, up to the 4 millimeter measurement, up to the neck of the A mount. So I like to do the flapless sometimes, and I like to put up to the neck of the mount to make sure that my apical coronal position is correct. And now when I'm doing an immediate, especially flapless extraction is absolutely required near 2024 to minimize a dimensional changes, then I would like to go around 4 to 5 millimeter. How do I do it? So now I drive in with the rotary instrument up to the neck of flushed with the free gingival margin with the neck of dental implant. If I flush that, and you can see that I'm in 4 millimeter. Now I'm going to engage a healing abutment that's 5 millimeter. If the healing abutment is coming a 1 millimeter above above the gingiva, I say it's good. If the healing abutment is flush to the gingiva, which is 5 millimeter in height, I say it's still very good. For immediate implant, 5 millimeter is very good. So 4 to 5 millimeter, I say it's very, very good. And you could reference it and use the landmark of the mount, a neck, and the healing abutment to get a correct apical coronal position. So we know how to use the mount, and let's see how to use the healing abutment. So now when you have a thicker soft tissue right here, and when you have a thicker soft tissue and healing abutment is showing only maybe a millimeter or flushed, I'll take it any day because biological width has been established. But if you have a thin soft tissue and healing abutment is showing about 2 to 3 millimeter, then I know that a biological width requirement has not been met. So I'm going to just drive that implant deeper so that my healing abutment is showing only either 1 millimeter or 0 millimeter flush to the apical margin. And that's how I control the apical coronal position. I like this position better, especially for immediate implant. I like to position my 5 millimeter healing abutment being flushed to a immediate implant. And if I'm using 7 millimeter healing abutment, it's going to be around 2 millimeter above the free gingival margin. So when I see a healing abutment looking like this, I say it's not bad at all. It's not bad at all. It's inside the bone and soft tissue, a requirement has been met. Now that's why in a thick gingiva, around 3 to 4 millimeter, then this is a kind of old. We want to go around 1 millimeter subgingival subcrestal insertion, about a millimeter. In thin gingiva, we might need to go in deeper to create that a transition zone. So when you see this, when you see a 3 millimeter of a silver color showing, and it is a color healing abutment, it's 5 millimeter healing abutment, certainly this thing is not very good. Whereas when it shows a 2 millimeter, this is borderline. I wouldn't like it. If it's showing 1 millimeter, I take it. If it's showing 0 millimeter, I think it's the best in the year 2024. It's safer. So as you can see, this is a 15, 16, 17-year-old implant, and it's been staying very, very well because it was deeply placed. And as you could, it's a very stable crestal bone, long neck. Deeper implant placement is the nice combination for a long-term stability of that implant fixture. For me, when I look at my old cases and when I see a very stable fixture, stable crestal bone, and a very good fixtures that I've been having for more than 15 years, it's all deeply placed implants for a conchocealing bone level implants. But if you do place implant a little bit deeper, it's going to be a big minus because if you place implant deeper, you're going to have an interference with the bone. And when you have an interference with the bone and you don't know about it, you say, "Ew, ew," you're doing it so tightly, and you send the patient home, and patient will call you and say, "Hey doc, my implant is loose. And then you get scared. You call the patient back into your office, and you realize that a implant healing abutment just came off. It's not loose at all. So what's happening? You made it so tight. How come it's loose? It's loose because it was squeezing against the bone. It's not engaged into metal-to-metal contact in that area of the conchocealing area of the conchocealing. So you must get rid of the interference. So how come it gets loose when it's squeezing the bone? Because bone gets resorbed and it gets tremendous amount of pressure from the healing abutment, and there's going to be the space between the healing abutment and the bone implant interface. So the strongest muscle in the body, which is tongue, is going to act on it, and the food is going to act on it, and it's going to reverse the healing abutment out. That's why patients bringing the healing abutment to you in their hands. So what should we do? Simply, we could use the bone profiler and profile the bone around. Um, I'm sorry to say, I don't like this for anterior at all. I'm sorry to say, Ostem, some things that I don't like, I have to say it. If you use this in anterior, it blows out the buccal plate sometimes, and it's a nightmare. So use it very carefully. And I really think that a Ostem should change the design of the bone profiler. This is a external hex bone profiler, but we're using an internal hex implant for best sake. So this is a bone profiler for all days, I think. And for in my personal thinking, bone profiler should look like this. And I wanted rotary and hand so that I could put a big wheel and use the kind of like clam ratchet bone profile. Maybe I should make it. No, maybe I said it so someone else will make it in this lecture. Be rich, and if you're rich, don't forget me. Okay? Anyway, this is the internal hex, not external hex, right? We're using internal hex implants, so the bone profiler should be internal hex bone profiler. Anyway. So I'm not so crazy about this, so I use it with my blade. Usually I use the 15 blade to profile the bone around. But I don't even do that most of the time because I know the dimension. If you look at 505 and if you look at 4.5 millimeter diameter implant, then you see a 1.7 millimeter a free space. This means that when you sink it less than 1.7 millimeter, then you're going to have enough room. But when bone is higher, especially if the proximal bone could be higher than your buccal bone and greater than 1.7 millimeter, then you're going to get an interference. If you get an interference, either you shave it off with the burr or a piezo or the A-blade or bone profiler. I like to use it longer. Look at that. Just by changing the A length of the A same diameter A healing abutment, I just have a 2.86 millimeter A free zone. If I really cannot do that, I could even do I could even use the healing abutment that's even shorter, smaller, and have a 4 millimeter diameter. Then I go 3.34 so that a bone could naturally profile themselves. So I don't like to spend too much time at the end. I like to engage the healing abutment so that a bone can naturally profile themselves. And if I do need to profile later on, I might profile later on. But I like to let the bone naturally profile themselves. I like that natural, a slim, acute angle that goes out. And acute angle is much better for soft tissue response and hard tissue response than a obtuse angle. Now, what about the labial palatal position? How much bone is enough for the labial palatal position? Labial palatal position is very crucial for maintaining the aesthetics and also maintaining the longevity and keeping the rough surface under the oral cavity in the very fragile area. So first you must understand where the blood supply is coming from. Blood supply is coming from periosteum and bone marrow and periodontal ligament. Recently, I formed the lecture, and you're going to hear the 5th lecture, GBR optional essential. That's my newest lecture that I just did, and after reading multiple journals and books and everything, and this is the basic. Basic is a blood supply come from a periosteum, bone marrow, and periodontal ligament to this buccal plate to keep this buccal plate intact. Now, you need at least 2 of these, according to my reading and my understanding. And no one really says anything, but at least 2 of these factors to keep that a very thin buccal plate. So now, when you see an extraction of the natural teeth has occurred, now you have a bundle bone left, and you have a periodontal ligament and a periosteum in the bone marrow. But usually it becomes like this, 2 to 3 millimeter if socket is untreated, 2 to 3 millimeters the buccal bone disappears. Why is that? Periosteum, even though you do a flat lift extraction, bone marrow cannot reach all the way down here. This is too thin. This is only cortical, cannot reach. And periodontal ligament is not really functional anymore, which responsible for about periodontal ligament histologically is about 20% of the periodontal ligament is consist of the blood supply, and that's going to be gone. So two out of three is gone, and therefore you're going to lose the bone. And you lose bone very rapidly after extraction. And this is what happened. Imagine if you take out the periosteum, then a 3 out of 3, then definitely the 2 or 3 millimeters is going to go out. You have absolutely zero chance. So you want to make sure that you want to do a flapless extraction. Now, this research I'm going to show you over and over again through my research. This is excellent research. His research itself was not very relevant to me, honestly. But how they did it, the methods were amazing because they actually opened up the flap. This research should be never repeated in dental history ever again because they removed the periosteum from the buccal plate and actually measured instead of measuring from CBCT that's currently done right now. So this research should be never repeated again, but it was done, and scientifically it's very valuable research. And they discovered that more than 90% of the patient had less than 1 millimeter of the bone. That's very thin bone. And we know that very thin bone resorbs, and very thin bone and very thin bone. Just for example, less than 1 millimeter, greater than 1 millimeter. If it was less than 1 millimeter, it's considered a thin, and it's it goes out very fast. Where the little bit thicker bone is greater than 1 millimeter, is slower a bone resorption is seen than a very thin bone. So that thin bone in the maxillary anterior or any anterior that's or a posterior that's less than 1 millimeter is going to go very fast. That is why a extraction with the flapless method is strongly suggested, and I'm going to go over this very fast right now because I'll go over it later on again. And when you see a dimensional change as after extraction, there's a huge horizontal dimensional changes than vertical dimension. And when you see this horizontal dimensional changes, maybe an immediate implant is unheard of, unthinkable, because it's too much dimensional changes. But when you read this paper very carefully, all this measurement was done after a flap extraction. So without flap elevation, starting year 2011, Dr. Uli Grundle started to treat the socket, and with this specific study was with the soft tissue, and they discovered that there's not much changes. And more studies come, and at the end, Tarnao, Chu, and Salama could have less than a 1 millimeter, which 0.1 millimeter changes, 0.1 millimeter changes to minimize all the socket changes. And that has to start from the flapless extraction. Lately, I've been thinking, this number might not be so significant. This number will give you the guidelines, especially for the beginner. But for very advanced people, you have to look at everything as in general. The patients say a blood supply, health condition, and all. Especially, was that a buccal plate was ever detached from that a gingiva or not? All those things are very critical factors. So, flapless surgery is not an option. It's a must-do. Now you can see a bone resorption over time. When do you want to place an implant? When you want to place an implant right here is an immediate implant. But when you want to place an implant later on in an ideal spot, it becomes a little bit more difficult because you might need to build your hard and soft tissue. But however, when you want to just place it, especially the beginner should really learn to place in the field ridge, then you want to take advantage of the A-ridge and place more palatally and natively. But this is not an ideal implant placement. This is just a compromise implant placement. So you need to make a decision as a clinician in your clinic that would you place implant like this or this. But most importantly, your skill level is important. What is predictable in your office? If you could do an immediate implant with GBR, no problem. But if you can't, you wait and you condition the software and you go into the field rich and place an implant. So, what you're dealing with is important also, but what you're capable of is also critical. So those two needs to meet together. If you know what you're doing, and if you know what you're dealing with, and if you know what you're capable of, you are going to get some type of predictable result. So when you have an insufficient width, there are many different procedures to make up for this insufficient width. As a simplicity, alveoloplasty is by far one of the simplest ways to make up for the insufficient width. and then the guided bone regeneration, and then the black bone graft, ridge splitting, mini implants, and socket preservation. All these things to make up for the insufficient width, and you use this technique accordingly, according to your a situation by situation. By far, all this method, alveoloplasty is the simplest, and then the socket preservation, mini implant, and then guided bone regeneration, and a ridge splitting and black bone graft are not, according to the hardness. Now, for labial palatal position, for Hyosin ET or a TS from OSTEM says a color should be 2 millimeter, a greater than 2 millimeter from the inside socket wall of extracted dentition. This just means when you place an anterior implant, put it as a palatal as possible and make your implant get in a direct contact with the palatal bone. We call that an osteoconductive with the palatal bone. That's what we want to create a increased I-BP value, increase an implant to a distance between an implant to the buccal plate. You want to make sure that you place implant very palatally so that you have the maximum a distance just like that. Okay, this is the labial palatal position that I really want on anterior and medial placement. In this area, we come out towards the cingulum. Now, also, another requirement is that to avoid losing the bone height. So now a labial palatal might involve, in order to gain the good labial palatal, you might involve with some additional procedure called GBR. But I want to avoid the GBR. Sometimes you cannot avoid the GBR. And many people think that when you just have the socket like that, you could avoid the GBR. But it is a study suggests that when you have less than a 4 millimeter of the buccal plate to the implant, you need to open up the flap. Now this is a very burden. This becomes a very big burden to the practitioner. So something like this, we do have another way to treat it, and I'm going to talk about it in the 5th lecture. I just made that lecture to how to use GBR optional or essential, and how to minimize all this complicated procedure and make a simple procedure, simple predictable procedure in your office. I do that lecture in the 5th lecture for you guys, okay? Now for this lecture, if you have a less than 4 millimeter, we need to really open up, or else we're not going to get a 2 millimeter as a final. And also, when you place an implant correctly, and when you have an atraumatic or a flapless extraction, then when you have a greater than 4 millimeter from the implant fixture to the top of the buccal plate, almost outside of the buccal plate, then you could just do an intrasocket graft only. And this is the most wonderful case that you want to imagine, because you don't want to open up the flap in the anterior. It's a nightmare. So if you could just simplify by putting in the bone graft like this, then it will be ideal. So for anterior implant, learn to place it very palatally so that you can increase the gap of a greater than 4 millimeter. So now we want to have a finalized a bone thickness of a 2 millimeter as a suggestive criteria from everywhere, from Dr. Spray, ITI Consensus, Woody Grundle, a Boozer. Everybody talks about it, and it's not here. Many people think it's all over. It's not here. Here, but we want 2 millimeter. I don't care how close you go here. It doesn't matter to me. For me, I don't care how close you go here. Here, we want that 2 millimeter, and that buccal labial palatal is the most vulnerable site to lose the bone. So as long as that we get the 2 millimeter, we'll almost guarantee the great profile and as natural aesthetic as is possible, as well as a wonderful maintenance of this fixture for a long period of time. So what we're aiming for labial palatal, to avoid the losing the bone height, I already told you we need a thickness to avoid a vertical bone loss. So horizontally, we want to have at least 1.5 millimeter. I think that 1 millimeter is still good, but we want to have 1.5 millimeter and 2 millimeter on the buccal as a minimum. I'd like to have more, and so does Dr. Uli Grundle. He would like to have at least 2 millimeter, preferably 4 millimeter, and all the studies are saying we need to have a good buccal plate to get the aesthetics and long-term GBR as a long-term success. Why do you think it's that? This slide might be one of the most important slides that we do. Because when you have a thick bone right here around the implant and thick bone right here around the natural dentition, we don't have any problem. I already told you, the blood supply coming from periosteum, check. Thick bone marrow, check. PDL, no, but 2 out of 3, check. So good. What about here? Bone marrow, periosteum, PDL. 3 out of 3, check. How about here? Now, very thin bone in natural dentition. Okay, you have a very thin bone in natural dentition. Now let's see. Wow. No, no, no. No, no, no. Around the implant, but around the natural thin bone, we have periosteum and PDL. 2 out of 3. Check. What about a implant fixture against the bone? Now, we have periosteum, no PDL. Unfortunately, very thin bone. There is no bone marrow in 2 to 3 millimeter in thin bone. There is no blood supply to reach all the way up to the cervical area. So unfortunately, 1 out of 3 here. Therefore, you're going to get crystal bone loss. Okay? So that's the major difference between a natural dentition and a dental implant is the presence or absence of the periodontal ligament as an extra source of the blood supply. So, as a suggestion for long-term success, you could do this implant placement is not going to last. Therefore, we need to really build a hard tissue to make sure that we have enough surrounding of the periodontium in hard and soft tissue, especially in this case in hard tissue, so that greater than 2 millimeter after healing, so that this implant fixture will be maintained with a proper aesthetic and function, and of course for future maintenance. So to avoid losing bone height, to summarize, same thing, 1.5 on the lingual, 2 millimeter in the buccal. Sometimes you could place just the intra-socket and it's okay, but sometimes it's too thin, it's not okay. So therefore, you might need to do an extra socket overlay graft to create a greater than 2 millimeter of the 2 millimeter of the buccal plate for better maintenance. And also, please pay attention for 1 millimeter over than a fixture length. Therefore, whenever I do GBR, I use a taller cover screw. There's a taller O-stand cover screw. They might not know, but you call and say, I want a taller cover screw. You could even use a lower healing abutment if you're confident to suture over to gain that thing. And or graft over, you could put a bone grafting and with a higher cover screw, and they almost definitely get this or get this soft tissue. So for the GBR, if you ever do it, the space maintenance is going to be the main key, a main factor for your GBR success in creating a proper surrounding of dental implants. For requirement of GBR success, you need to really put the bone graft material where you want it. So position and the shape of the augmented bone really influences the soft tissue profile. So when bone grafts start to escape everywhere, then you know that this profile of the soft tissue is not going to stay long. But if you could contain this graft material where you need it, remember where the cervical area, 2 millimeters where we need it, then you're going to have a very, very good success. Without even a soft tissue augmentation, in this case, we were able to attain this for 9 years like this. So, wherever the bone graft is, and wherever the augmentation of the bone is, then it's going to determine the soft tissue profile. And we want to really minimize the apical migration and the proximal migration of the graft material by putting in the membrane and fixing the membrane so that the graft material stays where it is. And now implant angulation. Implant angulation, you need to think about it as a fixture is representing the root of the natural dentition. So if the axis of the natural tooth is a normal, then really it should really match the axis of the natural dentition. So what is a natural axis of the natural tooth? So now a natural axis going towards the opposing a natural dentition is such that I'm sure that you did this in dental school one day, right? You did this in dental school. You did one of these in dental school to show the occlusal relationship between the two. So you want to go into the interproximal area like this. And of course, representing the center of the restoration is more important. And the angulation mesiodistally is going to be usually a mesial like this, so that you don't get any of the prosthetic complications. And knowing mesial tilting like this. So we want to make sure that implant represents the root of the natural dentition like this. But lately, let me tell you, really the modern method of the prosthetics is that you put the A implant a little bit from the canine, not perfectly parallel, a little bit like towards the angulation, like more perpendicular, so that it could be more perpendicular a axis with the opposing dentition, so that it could transfer the load its most effective way. So even though you're not perfectly parallel to the natural dentition, as long as you're perpendicular to the opposing dentition, then you're doing something really, really good biomechanically. And this is one of the most common this is common mistake that a practitioner make. And when I go to your country and do the hands-on, and I do see quite a bit. So this is how you place your implant, but this is the a natural curvature of the natural dentition. So now position and the curvature can change, and you can see that position of this implant was a little bit too distal, and the angulation of the implants was a little bit off. We want to try to follow, and the three implant right here should be really parallel. Now, this by far is one of the most common mistake the a participant makes, by the way. One of the most common mistake the participant makes. But implant represent the root of the natural dentition, where it's supposed to go following the parallelism of the natural dentition. However, because using a stopper, I'm going to talk about it in more detail if I do get the opportunity for hands-on. You could start originally nice way, but because of the nature of the stopper, and your wrist motion changes and become your osteotomy usually becomes perpendicular to the crestal bone, and it should not be like that. Especially, and you're going to place an implant in a very, very inclined area right here. And I see this is the ideal implant placement, but I see an implant placement like this. Why? Because using the stopper to button this to go with the perpendicular motion. You could start with the original, you could change it. So I want you to stick with the original. And I'm going to show you some of those techniques during our hands-on. There are a lot of different techniques during our hands-on that we're not careful of, and those small things adds up, and it's going to increase our predictability in our practice. So this implant should be placed a little bit like this. And if you place it too straight, something's going to go wrong. And a angulation is supposed to go to a functional cusp. If you could go towards the center of the restoration, I'll take it any day. But if you want to be exactly right on the angulation, and you want to be more meticulous with angulation, the position, my suggestion is go towards the functional cusp right here and here. So you do need to know what functional cusp is. For example, the lower molar central fossa is supposed to occlude with the facial incline of the lingual cusp. So if it's occluding, so you go right towards the middle and go to the functional cusp a little bit, just to change your angulation a little bit. That will dictate the ideal angulation for your implant restoration. Ideal force transfer for your implant implant fixture. And such, you can make it into cementable or a screw type or screw-mentable combination type by changing this angulation as well. Of course, sometimes the bone shape does not allow us, but we're going to do our best, try to do our best in our power to change the angulation as such, or a position and angulate the implant as such, so that we could compensate all this occlusive pressure as much as possible towards the axis of the implant. And now, if we can, we want to try to follow the curve of Wilson by a maxilla going outwards, mandible going inwards. But unfortunately for the mandible, due to the presence of the undercut, many times we cannot go inward. Many times we have to go outwards like that biomechanically. So you might think that bone shape is most important for implant placement. It's wrong. Number one consideration is biomechanic and force transfer. Number two consideration is the bone shape, guys. So if you follow the natural contour of the curve of Wilson and curve of Spree, then you will get a very, very good response in the near future or even further future for the patient. Now, if you do not place an implant with a good angulation, if you place implant with the off-axis load, you'll realize that every time you get some more angulation, from a 15 degrees difference will give 100 Newton off a center moment from a 180 Newton centimeter moment. So it's 81% increase. So just by putting your hands a little bit wrong like that, then you realize that you have caused many different problems, biomechanical problems, and possible screw loosening problem. When screw loosens, it's the mobility. If patients do not detect early, you're going to lose the crestal bone. And when crestal bone loss is occurring and exposing the rough surface, it now it poses a threat for peri-implantitis. And when peri-implantitis occurs and then bone does not support that implant, then implant could fracture. So it's all connected. It's all connected. It's almost like a domino effect. So we want to try to place an implant and drive the occlusal force perpendicular angle to the occlusal plane to definitely reduce the post-loading complication. So now this was the original best, and this was no, but I don't think so. This is not a no. I don't think so. This is as ideal as it can, but this is also very, very good. Why? Because if you want to have a correct biomechanics, you're forced to place implant apex towards the lingual undercut. So a usage of the short implant is strongly recommended. We used to place implant everything like this, but if we place like this and this, when you have a bone loss, then you're not going to have any biomechanics and good transfer. So you're going to have a lot of screw loosening problem and biomechanical problem in near future. So you're forced to place the implant in a perpendicular occlusion to opposing dentition, and you're forced to you might be forced to place the implant apex towards the undercut. Now, for implant angulation, we're going to try to make every implant parallel. And one of the tips is to utilize the mount and do not take off the mount until the end of the restoration stage. End of the implant placement stage. And use the implant mount as your indicator for parallelism. The position and the path of the implant, where you can make the patient bite and see where the clues to check your occlusal force scheme. Now, we want to make sure that it's mesiodistally and the palatally in correct position, and you must consider the final position for the screw hole to have a best of the retrievability. Now, let me go with our final topic today, a prosthetic consideration. I don't think I might not be able to cover all the topics, but this is webinar, so I'm going to try to cover as much as I can. And I'm going to do the lecture up to a 45 so that we will have some type of a 15 minutes of an announcement and Q&A session. So let me see how far I could go. So prosthetic consideration. This is the prosthetic consideration, and many people underestimate this prosthetic consideration, but this is general rule of the prosthetic consideration. And you want to place an implant in such an area to make sure that it could withstand the occlusal forces. And you might want to remember some of the numbers, where the premolars and the molars and the premolars and the molars, the crown size. Once you know this, it's much easier for you to do a plan for the prosthesis. So these are recommended diameter for the implant according to specific site. And these are some of the recommendation for the implant for the specific site. So as we go more posterior, of course, we want to have a bigger diameter, because if you do place a narrow diameter, and it could actually fracture. So there could be an implant tearing cases, especially when you do not place implant correctly. And this is the most of the problem. But there are cases with the patient with a parafunctional habit, such as a bruxer or clincher, which could cause a oldest nightmare. But now let's take a look. When you look at a 4.5 millimeter wall thickness of the TS3, then when TS3 is fractured, this is the wall thickness. My suggestion, try to change it right away using one wider and one shorter implant. So wider implant will definitely generally will have a thicker cervical thickness. You could compare it to 0.8 to 0.43. So it's unlikely that you're going to fracture the double thickness of the fixture unless patient has a really strong. But patient, you already know that patient has parafunctional habit, so you're going to replace that. But now you can see the changes in thickness of the bone. But you don't want to have this. You want to make sure that can you have a thick from the beginning. So now Not many people know about this, and this drives me crazy. I love TS4. TS4 is the most futuristic design that you could do, and I also designed a long time ago. I think by mistake. I think they designed it by mistake. They didn't think this design would be this futuristic. But if you look at the old implant design right now, and that's out there in the market, the most popular design is a very tapered design to enhance the initial stability. And this design is not just that enhancing initial stability, it also gives you better thickness. When you see a 4.5 millimeter in a TS3 versus 4.5 millimeter in TS4, you can see a thicker wall. 5 millimeter, zero point 0.5 versus zero point 0.8, it has a thicker wall. So if any patient with a parafunctional habit, if you're worried that it's going to fracture, then my suggestion is to go right to the TS4 and try to utilize that. You'll be very surprised that it works very well functionally. You might think that it might not have a greater functional, a greater surface area, but you're wrong on that because a measurement, the research suggests that this type of large pitch and a large pitch will give you the maximized functional surface area that's greater than TS3. So I feel that TS4 is really under a practiced, underused. So if you have an opportunity, try to utilize TS4 in a very softer bone, or maybe patient with parafunctional habit, or try to solve the complication, implant fixture fracture, with taking it out and insert it directly into that area with the TS4 implants. Now you can see a plaque zone and adherent zone, and we went over this with the transition zone. And this is a very good study. Well, this study I got it from I got a great tip from Malaysia. I went to a study group by Dr. Neo, which I truly have a huge respect for a true educator like Dr. Neo and Dr. Miao in that field. And I went to do a study club with them, and one of the gentlemen, and excellent young dentist, excellent lecturer, excellent young dentist who knows how to, who I think he's going to grow big. And he actually lectured, and I liked this lecture, so I took a picture and I took my own PDF from there, and I made own. It's an excellent. We knew this concept, but this a study presented very nicely. This study is on non Gomez meta, so I learned from everybody, by the way. So that's the thing you should do. You can see a zone E, B, and C, and the B and C's attachment, E is not. So this is not a true pocket. It doesn't go down that way. It goes down only to the sulcular epithelium, and this B and C zone is a boundary with the soft tissue. This is the initial perimucosal seal that gives you protection against the all this oral cavity irritants. Now you can see when you create a proper transition zone, and now you need to know what's the best design for a transition zone. So in order to create a best design, now we're thinking this type of design to create a proper emergence profile design that supports an aesthetic outcome. So we want to go straight and concave on convex when it becomes supragingival. So straight, concave, and convex. In order to get this, we need some spaces, and that's what we're saying. We need minimum 4 millimeter of the vertical spaces for the transition zone to make sure that we get this type of contour. So you get connective tissue, which this area that's a very affinity for a fibroblast, and junction epithelium binds to anything that's smooth and comes from the sulcular epithelium. So you can see the sulcular epithelium, junction epithelium, CT. That's why you don't probe deep into the implant, because you're going to break that seal. We know that a natural emergence angle is less than 25 degrees in natural dentition. So if we have anything that's less than 25 degrees in our emergence angle of our implant abutments and implant abutments angle, then we're going to receive something good. And this is Dr. Karafuchi's research, and that's very nice too. I learned, I got a very good tip from Malaysia, and very good. It's a shape, straight, concave, and convex shape. And with a straight and concave shape is more favored than convex, and any degree less than 30 degrees mesiodistally, any degree less than 30 degrees shows a less rate of the periimplantitis. Anything that was greater than 30 shows a more rate of the periimplantitis. Also, I already told you, straight and concave shows less, and convex show more. So, okay. But also, what about the buccal then? And that's Dr. Diego Lopes, the buccal a emergence profile, not the interproximal. Buccal emergence profile could be up to 60. Wow, up to 60, because we're going to place very palatal. But as long as we have a straight and convex and concave profile, I mean straight, concave, and convex profile, nice S shape, we're going to see a much less chance of the periimplantitis. So creating profile in transition zone also dictates a future health of dental implant and for their maintenance as well. So if you're going to design a CAD-CAM abutment, which I feel that in the United States, almost a 90+%, I think we design CAD-CAM if it's not over 95. But in other country, CAD-CAM is not as popular. But I guarantee you this will get very, very popular. So if this get popular, what kind of design do you want? You don't want convex design. You want to make sure to let them do the CAD design, computer-aided design, as a concave design like this, concave design like this, concave like that, to occupy more a soft tissue around there to stabilize the periodontium rather than having piece of the metal stuck in there. So profile, this profile, a preferred profile is concave underneath, so that we could form a good emergence profile with the abutment. We used to form an emergence profile with the crown. Now we want to form an emergence profile with the abutment themselves. And this is just much better orientation. Okay? So that we could have a less of the emergence angle. So for emergence angle, I'm going to talk about just a little bit longer. When you see a very stiff, like an obtuse emergence angle, you can start to see a bone loss due to biological width violation and the emergence angle. So when you see it, this obtuseness like this will really irritate the soft tissue, and this soft tissue condition will transfer to the hard tissue condition and cause a bone loss. So just by changing, with the same case, changing the diameter of the abutment will give you a more acute angle. A more acute angle more acute emergence angle will give you a less of the problem like this, as you could see, and less of the soft tissue problem, and thus less chance of the periimplantitis. So emergence angle is also very critical, and we do not want any soft tissue to become crushed by the abutment like this and unable to clean to cause all this periimplantitis like this. Okay? So there are both a horizontal and vertical vertical zone of the inflammation. And now with this prosthetic component, I'll cover it quick. I would suggest a platform switching platform switching type. Platform switching, you don't ask the laboratory to switch the platform. This implant itself is platform switching. So when you have a smooth color like that, then it's going to be platform matching automatically. You can see an oscillation going like this. And when it's smooth color, but when it's a platform switch like this, you see the oscillation is getting caught by the implant fixture, so that you don't get a bone loss. This is a huge difference. So now, as you can see, for platform switching, rough surface all the way implant, and allows the better stability of the implant fixture, whereas the platform matching will thin out and you don't have a bone marrow to support, and you have less a supracrestal attachment. As the unpublished research by Stephen Chu and Dennis Tarnow, you can see a more soft tissue volume around the platform switching than not. So I definitely think that platform switching is there to stay. And the thickness of the horizontal will allow you to keep that thickness of the vertical, and from the platform switch it starts, so that you could have a less of the thickness of the soft tissue but still be able to maintain the vertical soft tissue. So platform switching might be wonderful. Around here, I already told you 1.5 millimeter of the horizontal components is going to be lost. This is saucerization. But now, if you place a platform switching type of an implant, it starts from the abutment and implant joint, so that you can see a much less zone. This is less than 1.5 millimeter. So how does they clinically affect? Because if you put a 1.5 millimeter, and if you place the implant a little bit too closer to the natural dentition, and natural dentition is going to lose the bone, and that interproximal bone area is determined of the papilla. So papilla is going to drop. Whereas if you use the platform switching implant, you can see that a saucerization zone of the saucerization really narrows, so that a papilla will be not compromised. So it's a lot safer and for not just the short term, also for the long term. Okay. So I feel that up to now is a great presentation of the a review. I would say review of the 3D implant placement and some of the consideration with the prosthetic. I would love to do more and more, but I would like to take some of the questions that's allowed. Before I take any question, does a branch of the branch in Asia need to make any announcement in the future? I know that I'm going to have a next lecture at next week. Next Tuesday, I'm going to have next lecture. This is going to be a very condensed form of the webinar series. I hope that you could attend all 6 series. If you're not, you could attend whatever you can. But seeing me in a real person is very different than seeing me in a computer. Also, your attitude and your behavior is different behind the screen than seeing me in a person. So I would love to see all of you. But before I'm seeing all of you, I want to introduce myself to you guys so that I'm doing all this lecture to showing you what I know and what I could share. And if you like the material and if you like my way of presentation, please join me in Asian trip. And it's going to be a seminar is going to be in Thailand and I believe in November. November,
November
and
29th.
November, and I'm also going to probably go to Asia country in February and March, and if the country allow me so, I'm going to tour them all around so that I could share knowledge with the other practitioners. So, does Hayosin have anything else to say before I start to answer the questions? If there's nothing much to say, I'm going to start answer the questions. So first question, Doc, how deep should we place the fixture? What is the exact maximum millimeter placement should we go deep? There's no maximum exact millimeter, but there's a suggested millimeter of 4 millimeter after heel, so that when you're dealing with a immediate, you might go 5, counting, anticipating the socket changes, dimensional changes, or if you're confident that you can maintain it, you could just go 4. For me, I usually go between 4 to 5 deafness. If you go deeper than that, it's going to be longer neck, but oral hygiene might be an issue. So depend on your skill, you need to decide a protonal level. And is there any danger when you place much deeper placement? An oral hygiene issue might be the problem. So yes, the sentence call as shallow as possible, as deep as necessary is the key. But for the beginner, I suggest you go a little bit deeper. So 5 millimeter placement is strongly suggested from the pre-gingival margin. How many times do you put the chlorhexidine digluconate to plex on an implant? I just put once, and then I don't suction it out. I just put it once, I don't suction it out, and I do something else. I come back and I just dunk my implant in. So basically, if this is my implant placement and this gingiva healing abutment is taken out, I'm going to place it. I'm going to dunk my chlorhexidine in right here. I'm going to put chlorhexidine like that. I don't suction it out. And I'm going to utilize my abutment now. My abutment, I'm going to put that abutment back in here with the screw, right? With the screw, I'm going to put it here with the alcohol wipe like this. I wipe and then I just dunk it in. Okay? So that's what I do. And to promote an early adaptation, early attachment of the junction epithelium to the smooth color of the abutment. Second question is what do you? Second question was what do you do if you have a different soft tissue thickness in one patient? I think that you have the answer. What do? You go to the deepest area. That's what you do, or else you augment the soft tissue so that you can make the soft tissue level even. Okay, just like your bone level. Which one do you base on? Your lowest level of the bone. That's what you based on. Okay, fantastic. Okay, 1 millimeter below the crestal bone should not be the basis of the implant placement apically. Generally, yes. So the correct placement should be measure the soft tissue and then adjustment to place. Oh my goodness! Fantastic. You got it. So you need to go down deeper and make sure the total a depth from the neck of the implant and the gingival margin is around 4 millimeters. So 2 to 4 millimeter buccal bone, how far should it be? 2 to 4 millimeter on buccal bone apically on fixture. Okay, 4 millimeter, but apically 4 millimeter from the gingival margin. That's it. Will it only be cervical 1/3 of the fixture? It needs to be cervical and middle. Oh, 2 to 4 millimeter? Only cervical 1/3. That's it. Regarding implant angulation, if you have a missing first molar for a dental implant placement, which angulation should you follow? Mesiolingually tip the second molar, normally tip the second premolar. So I like to follow usually the mesial one, but you need to look at the tooth on adjacently. What's the tooth condition? And what is the overall arch condition? You need to look at the overall arch condition and place it accordingly. More importantly, perpendicular occlusion to the opposing dentition. Okay, so that's what I go by. If it's like a mesially tipped, I would probably do an enameloplasty or ortho or put a crown on it and tell the patient that it's much better for the patient. Okay? Or else you just gotta compromise. The patient don't have money and don't want to do anything. You just want to place an implant. You need to do the enameloplasty as much as possible to get a best of the path of insertion so that you can minimize all those gaps. Sadly, we don't have a TS4 in Thailand. Okay, it's gonna come out soon. Don't worry about it. As mentioned in your lecture, does crestal bone is important for a implant longevity? Absolutely. How do you suggest to address dental implant which had a peri-implantitis and had a bone loss already? Would it be better to remove and change the implant? That really depends on your decision-making process. If that implant is an abutment for a 10 unit and has been around for patients' mouth for more than 10 years or 20 years, then I'll probably try to treat it peri-implantitis. Now, treating peri-implantitis is a totally different game. Peri-implantitis should be treated by the resective surgery or regenerative surgery or both surgery. Depends on the shape of the defect, you will decide, and depends on the severity and degree of the defect, you will decide whether or not you will extract or not extract. If it's more than 50% of the implant surface is damaged, then you need to extract that implant. If it's not, look at the shape and you might want to decide a resective or a regenerative method. But if you just placed an implant 3 months ago and you start to have a bone loss and about 4 millimeter bone loss on the buccal, and you think that you're going to treat that a peri-implantitis and put the bone back, you're doing something very, very wrong. These implants are just coming out very easy with the reverse torque. And you could place a new implant with the more polypally and maybe more a short implant, and you could do a GBR in a fresh implant surface rather than a contaminated implant surface. So it really depends what to do with your peri-implantitis. But you're absolutely correct. A crestal bone, not losing crestal bone from the beginning is the key to maintain the implant. So surrounding is important. You need to create a wonderful surrounding of the hard and soft tissue around the implant. How about apical fold dimension of the SS implant placement? SS, AGS, ET, TS for me, almost same thing. As long as the rough surface is buried 1 millimeter underneath the crestal level, at least 1 millimeter underneath, I'll take it any day. I'll take it any day. It needs to be underneath. So even with SS, I like it to be. If I place SS right now, which I don't place too much, but I like it. I like that fixture for posterior. So if I place SS now, the rough surface also need to be 1 millimeter underneath. It's not as crucial because you can have a 1 just right even, but I like to still have 1 millimeter underneath, and I feel that it's much better in long-term survival. Much better. So any rough surface, so I don't care which implant design, any rough surface should be a 1 millimeter. That's right. What about considering a customized consideration placement? Yeah, if I do restore, probably 100% of my abutments are customized. So I like to do a customized abutment. Yes. And what are the consideration? That's like the whole 3-hour lecture. So I'll probably go to the country and walk to I'll show you the consideration for a customized. Okay. Okay, how do you modify healing abutment to achieve a good emergence profile? Well, you could certainly do that. That's a little bit more advanced, and I'm going to talk about it over and over in a webinar. So definitely you could expect that answer in future webinar. Do you recommend using a composite material healing abutment? You could do that, or you could use a, for customized healing abutment, you could also use a temporary cylinder like a gold abutment or any type of peak abutment, and they just built a composite around it, especially for a maxillary premolar where you have so much discrepancy between mesiodistal and buccal-palatal. So maxillary premolar is usually elliptical like that, and there's a discrepancy. So you want to make sure that you want to get this good profile, then customized healing abutment, customized impression coping. That's going to be a later during the hands-on or a later during a master's course or somewhat. Okay, guys? All right. Now, how do you modify healing abutment? Yeah, same thing. You just got to modify it after extraction to get a good transition zone. If you could copy an original transition zone from the natural dentition, that's the best way to do it. Okay? So hopefully I can show you. Right now, I think we're running out of time, so I need to do about a couple more lectures on that. So I think that in my future lecture series for Asian lecture, I think for my future lecture series webinar. Next one, future lecture series, I think that we're going to try to cover a very similar. But like I said, this is a presentation. This is the conference. And you get a best of the learning from all this hands-on. So you go to conference and see, and you want to know the details in hands-on. If you think that this is detailed enough, it's not true. Okay, all the small trick with dentistry, we have to get in hands-on. So hopefully, you can speak to the Ostem or Hayasen regarding. I'll answer. This is the last question I'm going to answer. This too. Okay, last question. I think same people are asking all the questions, so we need to give an opportunity to other people. At the same time, I think the time is almost over. So you could come into next webinar, certainly, and we can answer questions more. Is it possible to put a fixture deeper after a number of months? Let's say I want to put deeper than 1 to a 4 millimeter. Yes, it is possible, but this is a very unorthodox. It is possible, especially around the sinus lifting, and that's a very small trick that I talk about during a lateral augmentation. But this is very unorthodox, and you should not use this as a regular method. And that's my answer. Final question: do you suture bone graft? Do you suture bone graft? Flapless immediate implant placement to immediate fixture. I think that this question is a little bit off. I'm so sorry to say. Do you suture bone graft and maybe on flapless immediate? Do you suture in flapless immediate position? I guess that is it to try to minimize all that. But that's a totally different lecture. It has nothing to do with this. And when you look at a future lecture in second, third, fourth, and fifth, and sixth, and so on, and these things will come out. I guarantee you, the bone grafting, immediate implant, flapless, those will come out. So you need to organize your thoughts and be able to go step by step, and I'll do that for you. In a mean, but this 6 series is not a master course, guys. This is a presentation to give you an insight to be interested in a dental implant, so that you could study further and make sure that you could do a very safe and predictable implant dentistry. So hopefully I give you some motivation and innovation, and I'm going to hope to see all of you in next week at the same time. And I thank for Hayosin Ostem Asia for giving me this wonderful opportunity to speak. Okay, guys, I thank you so much, and see you all later. Thank you very much. Bye bye. See you next week.
Thank you for your excellent lecture today, Dr. Davidson.
Thank you.
So we're gonna share a new link for next Tuesday by each country representative. Then in Thailand, I'm gonna share a new link for next Tuesday by line. Okay. Thank you. Thank you for joining today.
Alam mo na wala
beating around the bush. As in, inuulit ko na kami mga ref, pero like, what are you trying to say? It doesn't make sense.
go with the passage of time.
sinabi niya sa isang wala daw active military ngayon around the world. The war has ceased.
Sa debate po.
Tapos, yung mga binunod,
Mga military sa war.
That's a lie, what are we? Nagulat ako nga, the black community is not voting for her.
Malaki lang yung nag-change ng mind. Pero, generally, black pa rin sa Democrat.
Oo,
Parang
sa
sa
Democrat.
lang.
Pero like karamihan lang. Hindi.
Ay, bumoto na kayo ng 4%. Ngayon kasi nag-15%. So, grabe na daw yung...
Exactly. Wala lang silang choice eh. Pero for them, mas worse kung mas worse sila like. Nagulat din ako. Kahit may Indian community.
Alam mo yan? Eat the can.
Si kasi sinabi ni Trump yun na ito yung nangyayari sa Springfield, Ohio. Tapos may mga nakapost sa Springfield. They're agreeing sa atin sa Springfield. Kaya na parang
Ano kasi yun, yung Springfield, Ohio. Before pa lumabas yung debate, mapapanood mo na yung nila sa Fox News na nahihirapan na yung mga tao doon kasi kinakain yung mga duck. Kaya mga duck doon, talagang nasa mga ano na para sa Florida, ganyan. Yung mga tao nabibigyan yung mga duck business na ginagawa. And then they eat it. Tapos, yung mga, yun na yung napanood ko. Yung debate. Ako naman, oo. Kasi sabi nila yung kasi binrif siya nung lahat ng question.
Hindi naman ang lamig ng Panginoon, siyempre buo yan eh.
Lahat kasi yung ABC na best friend. Kasi ayaw niya.
Yung hindi parang ganito, yung square
So,
meter,
ginanay niya
hanggang
kasi
anong
parang
height,
yung goal.
di ba?
Ano
Kasi
gusto
yung
mo
square
na
meter,
ayaw na nila.
alam mo, 2.5 yung ano,
Ayaw na,
2.5 ng height
iba kayo eh.
Hindi, 2.5 na yung okay lang sa square meter
So
na.
anyway, natawas siya.
Even na yung Fahrenheit siguro. Even yan.
So parang
Kasi ang aircon ng Fahrenheit
at
niya,
that
kanya,
moment,
mapilit na
meron
eh.
silang fact checkers.
Hindi naman nakakataas ang lamig yun eh. Babae.
Officials say in Springfield that there was no incident, not one incident of pet eating, blah, blah, blah. So hindi nagkikipag-debate si Donald Trump sa isang babae. Ang debate was happening, 1 versus 3. Kasi dalawa yung moderators.
Kaya paano ba kung high ceiling ka?
Lahat ng ano nila, walang tungkol kay Kamala, walang tungkol sa pamamalit nito. Siyang czar ng border and not anyone na pumasok sa safe may myself or may free access pa rin talaga na rin sa mga state. So may bus ka. So ganun yung immigration sa So wala silang pinag about Kamala.
Alis ka na ba? Sandali lang, siya ay magbalik na lang.
Okay, sabi nyo, normal. Pero tangina nung tinawanan siya ni Kamala. Tapos nung dinibang siya ng Springfield, Ohio, doon na nag-viral. So lahat ng Democrat. Diba pa? Parang beach drinking. Diba? Ganun naman yung gagawin nila.
No, pero yung it's really happening.
Yun nga.
It's really happening sa spring.
Hindi, kasi naman yung beach drinking, hindi naman sinabi talaga nila, how about we drink the beach? Parang alam naman yung nagawin mo yung donuts. So parang ganun yung nangyari. Pero gagawin malaki yun na Democrats. Ang nangyari dun sa text, hindi nila nagawin kay Donald Trump because in just 24 hours, 120,000 ang nag-upload na eat the dogs, eat the dogs. So, pinagin nila tumaas. So, lagi lang sa umpisa, papalala. Pero in return, grabe
Yung mileage niya.
Kasi di ba lumalabas na wala nang pusa sa Springfield? Wala nang stay cash.
Ano nga, nag-debunk na yung mga tao mismo sa Springfield. Dahil na, it's true what you say. It's not lying.
Oo, at sasabihin mo na shit ng dogcat na tubento ka lang sa mismo.
Grabe yung poverty talaga. Grabe
Grabe.
yung ano. At nag-shoot ang population talaga nila at one point sa talaga.
Sa Springfield, Ohio, ang may pinakamalala. Alam mo yung nagdadaan nila doon sa mga homeless, tapos puro added sa mga homeless. Sa Springfield, inubos nila ang mga good citizens ng Springfield. Bakit po good citizen na mag-stay ka sa Springfield? Never. Wala namang kabuhay nila ng pagkakas. So yung mga nagpipilitira doon, survivors yun. Tapos ginawa nila, hinintay na sila ng pack na kinakain ng mga pets nila, yung mga bees nila na pakalaki. So, ganun yung bayaan yung mga tao because you just need to admit the truth. You cannot accept the truth. Accept it, it's hard. Diba? Ano lang yan. So,
Oh, I have a feeling from naman yung Pilipino.
hindi, masyado talaga may agwan.
Kaya salvage ko naman yung camera.
Kasi si Biden, hindi, yung ano naman, pwede kasi manalo si Kamala sa sila Biden. Ang nangyari kasi mali yung turnover nila. Because Biden parang sinay na sa debate, gumano na siya.
Ang sinasabi kasi nila, nakaupo pa kasi si Kamala as Vice President. Pero wala siya sinasabi sa mga very problem na
Wala siyang policy.
Yun pa, wala siyang policy. Kaya yun yung medyo yun yung buka sa kanya na yun. Tapos pag sobrang malaki, parang nasa ako.
Ay, natulog na lang sila sa akin. Mahal ka ng joke.
Best dinamit ko. Sige.
Kasi ano ba kinain mo?
Kasi tinumuya yan dyan, hindi yan yung
Kasi sabi, alam mo kasi sa amin kasi wala rin pa ako sa sinipon bukas.
Sige, side shot.
Siya lang.
So,
Wala pa ako sa sinipon bukas.
wala ba tao kanina?
Gusto nila na kasi gusto nila kasi ako susundo. Hindi na pwede. Sa Pilipino na.
Pero kamusta siya daw sa school kanina? Okay naman.
gusto niyo kasi yung 1 week na kasi gano'n eh.
Or sabi mo summer, I walk or I tricycle.
Ay, tricycle. Pero cute nga yung sa tricycle, di ba? Sige. Isa, ayaw niya na sa baby seat, so kanan siya. Isa, so dalawang stroller, isa sa kanan sa ulo tricycle. So yung pag-tigate na sa driver. Tapos sabi ko, ayun ang service. Pero patuto na ka. Ano bang grade tayo? Mag-isa na tayo ng COVID. Ay, di ba?
Sinusundo din.
At isa?
Iniiwan ka ba niya?
Tricycle ako sidecar.
Parang mga grade 5 or 6. Pero hinahatid ako lagi ni mama papasok. May pa-tricycle ako pero parang lagi may iwan sa gala.
Binibenta. Ito kaya yun?
Nakapit lang naman.
Uy, allergy ako.
Allergy.
Allergy ako. Sobra dun sa rooftop. Pero kasi sa lipod. Or sa may itlog na.
Talaga ba? Ano ko nalaman na ano ka?
Grade 5 pa ako nakapasing sa mga ganyan. Nakakaila ako na yung high school. Di ba nag-aano yan? Ang gagalisan.
Kung malaman kasi naliliran niya pa rin eh.
Oo nga,
Dati parang
naliliran siya.
nag-bakit tayo dati.
Kasi pwede naman sa atin yan.
Kaya nga.
Kumakain naman siya nga.
Lalaban na.
Sobrang iba-iba lang sa
Yung cheese.
calamares.
Dapat isabihin mo
Huwag
kayo
yung
hindi mo
sweet
na
sa
serious
lasa
na.
niya.
Parang ayun na siya. Parang yun na.
Dalawang kilo.
Baka makuha niya allergy niya.
Dalawang kilo pwede na daw.
Chef ice cream.
Malakas ba kumain sa sabi niya? Talaga?
Matutuwa ka doon. Bisita ka ulit. Ulitin mo.
Nagsasalita?
Nagkuha ka ng show. Rice fix niya gano'n. Dati kasi gano'n siya nangyari. Eh si Shana lagi na yung wikis.
Ayan, ikaw yan eh. Nagagano
Sabi ko,
Siya, di ba?
ayan, mga gano'n. Yung gano'n na akala niya yun yung fried. Yes, mga gano'n siya. Ang kumilig. Di ba gumagana niya?
I wish you would lang ano kay Furnish Body.
Ano yan?
Nagagamit ka ba yung unan?
Oo.
Anak.
Manilas. Brad.
Ano na ako?
Ay! Edward! Kamush! Thank you ah. Salamat sa pakita. Kasi mo na rin. Bye-bye.
Yeah. siya. Ang dami, fit siya. May asawa na siya. Ay, kapit mo Jeremy?
Caracas.
Kaibigan niya si Jeremy.
Hindi.
Baka wala siyang asawa. Ano yan?
Pero meron
Pero andyan pa rin siya. Wala, umalis sila.
siya na car na yung Jeremy. Hindi siya yung nakakita kay Jeremy. Malaki sa may
Solo?
Oo, sa may...
Baklaran ka?
Makapagalaw. Pero hindi sa loob, sa labas. So, ginawa niya, kasi di ba may kaya yung Jeremy kasi yung galing ko sa sakay, hindi naman hotel, parang nakakauch siya sa SUV. Hindi naman, si Jeremy, ginawa niya ng, bintana. Tapos si Jeremy dito, pinababa yung bintana. Wala, alam niya siguro di ba, pinipipitan niya. So, ganito ginawa ng Jeremy, bumato. Ginawa niya, tigato. Kasi paano gusto niya lang igaganto, kung kumano si Jeremy, kumanta niya. Wala lang naman kay Jeremy, sino patabi ko si Bruno?
May katabi ba si Jeremy?
Kasi yun yung gusto niya kabuli. Wala lang kay Jeremy, makilong ka na.
Very good. Very good siya. Ayun.
Naka-front.
Sino ang galit? Pakiklara na. Sir.
Si Edward. Kasi may, alam niyang may lalaki eh. Oh, ano ka, alpa ka, di ba? Solo ka, di ba? O, ito. Ang hinabaw daw. Alis ka. Kasi hindi natuturuan si Jeremy. Never siya na-take. Hindi siya nalumaki na may natin. Hindi siya naturuan na tama. So, ikaw yung magtuturo, mahirap yun. It's gonna make you go crazy. Kasi mataas yung testosterone niya. Pero pag tinapatan mo siya ng testosterone niya, baba ka.
Ayan. Lumapit tuloy yung aso.
Aso ba?
Rodent. So, anyway, does that answer your question? Karakas mo rin.
Jeremy po.
Jeremy.
Kasi King Lebron. Tama? Kaibigan siya.
King for dance.
King
King
Carol.
4,000.
King Charlie.
King Charlie.
Hindi niya alam paano matain yung testosterone.
Iyan mo, i-require mo siya.
Kahit ako lang yung require ko.
Uy, happy na mo na yan. Sabi mo, I will take it to
Diba, sabi ko sa'yo, taasan mo yung galit mo. Kahit hindi naman yan yung
Ako na naman. Susupa na naman ako.
Asawa ka na nga ako kay dad nga lang kayo pag
Hindi.
nalaman mo.
Ano mo lang, hindi mo siya ikuporte, di ba? Kasi iba naman na yun.
Hindi. Pabisita na sa shell.
Para hindi kayo mabot doon, kailangan niyang may
Ipatulfo na yan.
Several papers.
tuturuan mo siya, mag-effort ka, hindi pwedeng lalabas ka mabait. Kasi kailangan, hindi siya, yung testosterone niya, hindi mo yun na babae. Kailangan mo, ano siya, at iba yung power ng galit, naniwala ka. Jeremy, kahit nga malambing yung sabi ko, kahit magalit ka, basta bigyan mo siya ng emotion. Bigyan mo siya ng emotion. Kaya niya.
Sabi mo, bibigay ka ng ano?
Ay!
Wala ka.
Para yun kay, hindi naman yun para sa iyo.
Hindi naman siya.
Kaya niya, kaya niya 20K. Kaya niya ng 20K tignan sa bata.
Bakit hindi siya pinilipat?
Alam mo yung din ang grabe yung campus yun. Alam niya to eh. Alam niya na yung bahay.
Sino ba si Edward? Pinulian ng babae. So, asawa niya, ito naman. Kahit mag-iwalay kasi, hindi na siya kahit nag-uusing mo yung voice ng anak niya, hindi naman babae, 20,000
maniwala ka. Kaya mo siya.
Kung mawala na lang kayo siya sa face of the earth. Ano sabi ko sa'yo? Dati yung babalik yan sa'yo, may sakit.
Oo, nadami kita sa nasa mortgage siya sa sakit dito.
Oo.
Bakit?
Ang dami ng excess value. Literal, nagtitinong yun.
Curtain yan. Nakata si Chris.
Brad, si Ed, si Edward, nakapalupin mo mga kasi naalala nila siya yung nakakita kay Chris sa Edward. Tapos sabi ba hindi daw yung nakatuluyan ko. Sabi, di pa nasa sila nakarama si Jerwin.
Yung pala, pupunta rin pala si Ano sa ano.
Hindi natin naman din ang mga tao.
Uy, parang mabigatan yung dala mo. Kasi
Hindi, ibigan.
Sige lang na siya.
Pero Chops, yung mga kapatid mo,
Feeling nga, kapalitan ka.
friends mo ba rin? Di ba nag-picture ka na may dinner kayo, may mga dinner kayo?
Dati, oo.
Dati.
Pero ngayon,
Ay, nasa may kotse.
Nagdadala siya ng babae, yung picturean niya kasi promise yun.
di ba yung ayaw sa kanya yung magdadala siya doon? Keeping it deeper doon. Sabi niya na, sana hindi mo nire-report. Tapos nire-report sa akin, wala lang naman.
Pag-picturean mo kasi.
Ayaw na doon, yung Sabado. Ang hila rin yung mga anak ko. Baka yung labo, Diyos ko, katas doon. Kung ano. Kasi baka yung spirit doon sa babae.
Hindi.
Kaya CCTV na. Hindi yun. Pero wala naman na. Kasi wala naman kami nga. May ako ba?
Bakit magkakain ka ba?
Hindi ko lang nga. Wala pang septic tank. Pakaalala yun.
Magiging kayo din yan.
Hindi na, Lord. Hindi na. Kasi sana yung 1 hour, 6 years.
May mga bagay tayo na niraw-ran. Dito be together. This is not it.
Pero kasi, sino ba ang pressure teacher? Pinakamalaking pressure niya. Sino?
Wala. Hindi niya hinahalaga na anak niya. Hindi. Comfort zone to. This is a
Comfort zone
backup.
niya
This is a
talaga.
backup when all things
Correct.
fail.
Correct. Tingnan mo. Pag yan nga,
Babalik ka na may sakit. Sabi sa'yo, magkakasakit yan.
at saan siya, tingnan mo. Pag
Exactly. That's why when it's
Naman
divorce
siya, naman
comes,
siya.
divorce comes, I'm telling you, kaya dapat nag-iipon ka ng anak yan. Hindi mo para pahirapan ng buhay mo. Dapat aalagaan mo yung bumalik ka ng may
Sigaw
sakit.
ang mga aalaga.
Hindi, no. It's a choice in life na pwede mong iligaw. It's not fair. It's not fair. Tayo ako sure na ako sa dami ng excess value niya sa life, sa dami ng communication niya, kakasakit niya ng isip.
Miss ko magkakain ko makakasip. Diba?
Kaya makakasakit kasi
Nakalis.
yan.
Like, lumaki siyang purulog ko. Tapos ito na yung given na, meron ka ng pamilya. Tapos gusto mo rin ng child, I love you.
Yeah.
Ay, hindi na ako
Nag-happy
eh.
birthday sa'yo.
And then, I
Tell
love you
mama.
sabi. 4,000 after one day. I love you. I love you, Ana daw, sabi ni Lisa. Sabi ko, what's your
I
reaction?
told you
I'm
guys,
surprised.
it's gonna be, she's the biggest treasure he will ever
Pero,
have.
diba?
Pero nag-blind daw siya sa kotse, nag-blind siya sa girls. Pero territorial kasi yung lalaki. As long as nakikita niya siya dyan na single, sa kanya siya.
Exactly.
Sa kanya siya.
Exactly.
Very
At hindi
very-
nila napapakawalan ko alam ng iba.
Yeah, yun pa.
Wala kung nakita ka ng may iba na.
Magpahalid-halid ka nga lang
Kasi
kasi
sinabi,
sinabi.
hindi siya yung parang, ay ako,
Okay lang
uy,
naman.
magkukotse lang tayo na, oh man, maganda na yan, na at least ganito ang buhay natin, maluwag ang buhay natin, magta-tricycle kami, hindi siya ganun mag-isip. Ang isip niya is crazy kasi hindi siya napalaki ng lalaki. Hindi siya napalaki ng tao. So, wala. Yun yung mentality niya. Hindi siya na ano eh, napupok sa ulo. Parang, ito yung border mo. Lalaki ka, may border na. Hindi siya na, iba ang mind ng lalaki. So, wala siya pang, ang mag-border na yung babae. Kaya malakas yung power ng babae. Kasi, pero ang mahirap kasi, syempre, hindi kaya nung ano, si John kasi hindi. So, yun yung mahirap.
Tatanggapin mo
Sabi na
Hoy,
lang,
ano?
compassion is a sin.
Hindi kasi, compassion is a sin.
Compassion is a sin. Kaya
Magpahalid
mo,
ka na lang sa lalaki
Hindi
para
ka
tumiyo
mapapayagan.
yung pag niya.
Hindi kasi ang ano naman kay John, pwede na maghanap ng iba. Eh, hindi siya naghanap. Kaya sabi ko, pwede naman sila maghanap. Siya na.
this is not it. This is not one of those na irarandom mo ka.
Hindi na.
And also, subo ko sa'yo to.
Sure na sa'yo. Iba kasi ang nanay. Iba ang nanay. Hindi, suyo ko na kasi tayo makamatay na. Ganito, Chos. Makinig ka. Maghanap ka ng lalaki. Hindi ito para mapalitan siya pero you need help. You need a masculine figure. It is the biggest help you are going to get in your life. It is the biggest model Sam will ever have in his life that his mom has had. Kasi yung testosterone level niya, tataas yan. Hindi niya mag-puberty yan. Kasi yung mom niya, alam niya mag-isa. Nature yun. Na he will do something for you, for your femininity. So pag ang bata matagal mag-puberty, ibig sabihin hindi ko na kailangan protektahan. O yung babae, masyadong maaga mag-puberty ang babae, ibig sabihin, hindi pa siya kailangan ipaasawa. Parang ganun. Parang hindi pa siya naghanap ng partner. So,
Sit down.
that's the biggest help you can ever give to Sam. Summer, mabalik ang babae.
Kakayanin ang babae.
Lumayan isa ako. Kasi agreeable lahat ng babae. They're very social. It's for Sam. Tsaka ito, Jota, bakit hindi? Yeah. O pwede, legal. Hindi, pwede, hindi ka naman magkaka-boyfriend ng legal. Mahirap yun. Pero, kaya mo talaga. Isang part doon, kaya mo kailangan maghanap ng lalaki sa life mo. Aside from Sam and you need help. You need to admit that you need help. Kahit wala na yung sa'yo na makita ang jury ng iba. Walang ganun. Wala lang, tataas din yung puberty sa Sam na. Alam mo ba kung puberty si Summer? Si Summer ang makikita mo mag-puberty kasi yung lalaki, late talaga. Magkakaroon yun si Summer, take this. No, take note of this. Bakit maaga mag-puberty si Summer? The only basic reason is in psychology. Kung bakit umaaga yung puberty ngayon ng mga babae, hindi to yung kay Summer. Kasi kailangan magkaroon ng masculine figure ng bata. If not for that reason, what else? Bakit aaga yung puberty ng mga bata? Because they need a man. Men are important. Pero independent tayo. Independent naman tayo, di ba? Kaya natin lahat. Kasi independent nung isang araw, umiyak siya sa, Orlando podcast, di ba? Umiyak siya. Sabi niya, nagbalik ko sila ni Orlando after 100. Kailangan na, I need help. Wala na. Sabi niya, bigla siya, I need help kasi independent ako lahat. Kaya ko lahat ng news. I live being independent. But I learned I need help. Hindi ka balik kasi namin dalawa siya lahat. Pero anyway, mahirap magana ako. Hindi naman yan isang take advice mo ka about it. Mahirap din yan.
Yes.
So, it's more, it's for the puberty, psychological.
Lalagyan na natin yung mukha mo sa mga baby.
Teka, marami may gusto dyan.
Tapos mo yung
Marami yan.
Bigla na may message sa video. Sa Tinder.
Swerte naman ang jowawi.
Pag nakita niya sa Tinder.
Yung kapatid lang. Mag-post na nga yan.
Nakita ko kayo!
Makita mo ako sa friends pa rin sa pa rin sa Facebook. Hindi. Messenger. Messenger pa. Post ka lang sa mga
Stories.
May ka-holding hands ko niya. Pero pag may nakita, di ba?
Patay.
Stories lang.
Oo, ganun lang.
Okay, nakakawa.
Messenger yun, di ba?
Ang makikita sa private, hindi ka na 40 ka na, di ba? Gawin na natin lahat. Gawin na.
Gagagag lang naman eh. Oo. Masaya naman eh.
Lakas niya naman eh, no? Ba't di mo ulit kunin yung rubber shoes? Dikit mo sa ano. Baka nga mataas na yung value ng rubber shoes niya.
Ano ka ba may bibili na ano? Dati 8K, 12K yung binibenta mo. Pinost ko sa Facebook.
Pero ano bibili ka?
12K, 8K.
Di ba may value na yun? Baka mga, ano yung mga ganun daw na rubber shoes pero dati mga 30K mo. 50K o mga ganun.
Sa noon niya, ganun pa rin. More ba? Crazy. pala. Child support. Takot na ako
Yung
next month ako nung card eh.
Naging 4,000. Meron pala. Ay, naging 4,000 na.
Alam mo, napaka-trade party na. Ay, napaka-trade mga pangyakot na ng December to. Totoo alam ba niya?
Hindi ka kasi maangal eh.
Swerte niya.
Kaya,
May pangin. Ganda ng mansion ni Dutty.
no, siya po, hindi na kaya.
Tingin ko, titigil na lang.
Alam mo, parang yung ibang tao tatagad. Kasi di ba, nakakaya ko hindi guys. Hindi ko lang, kung may ganun bang konsensya, o tututuruan siya ng Diyos sa gusto mo kami na po may lahat na sa iyo.
Bakit ba? Isa lang ba girlfriend niya?
Ano?
Bye-bye ba?
Bye-bye ba?
Meron tropical storm.
Kaya matapos sa 25% daw.
Tomorrow?
Pag talaga bumalik ka ng visa, itapon mo sa ulo yun.
Kung ano. May imagine ko kung nakasalubong ng
Luto.
Hindi mother talaga siya. Super direct. Kahit ang gabi niya si Jervin, she's still going to be a mother.
It will remain far from that and not directly affect the country. It may exit the Philippines.
Pero, yung nag-dress umaga.
Wednesday, bukas na gabi hapon na exit na siya.
Pero lagi siya umaga.
mabilis.
Dito na nasa may North Luzon eh. Tapos baka si China ulit. So, mga pangatlo na ni China and since anything.
Hindi ko sabihin sa China, parang as in so
Vietnam,
Pati
China.
Vietnam.
Si Enting, ay hindi pa si Enting. Sabi mo na. Basta din yung lumakas sa kanila.
papatawin mga Chinese.
Gawin pa.
Bakit?
Hindi, talagang nililipat sila! Sobra yung bagyo doon.
Kasi yung COVID na mawala na, di ba? Yung mga pasyente natin, kung ano pupunta na ng Cambodia.
Illegal. Hindi nakapag-secure talaga ng
Very fast, very fast.
Yung ibig sabihin yung mga
Uy! Dapat tinanong mo.
illegal talaga.
Running man, tapos meron silang kapondo. Sa benta na nila kasa. Running illegal.
Hindi, makalagay doon from ano siya. Since Santa Nila na
Bilhin mo paluging cards.
British nila.
Yung iba dyan, ang signature nila na SBTO. Yung iba naman, nag-rebrand. May iba na, sinasabi lang nila yan, pero meron silang ibang pangalan na, ano, na parang certification.
Parang dito eh.
Sa Paola, ang ginagawa nila
Ganun lang, binabago-bago lang yun, hindi nila pwedeng i-eradicate yan ng todo-todo kasi malaki yung pera dyan. Pinakita din yung gobyerno dyan, maniwala ka sa mga yan. Circle namin yung ano na yan. So ginagawa lang nila yan dahil kay Alice Bo, again, hindi si Alice Bo ang pinakamalakas. Ang pinakamalakas talaga.
Never,
Isa lang
hindi
siya.
siya talaga.
Isa lang siya. Baka nga yung gumagawa pa yan, ubos ng competitor eh.
Oo, yung naman pang-uwi ng Islam or ano.
Diba? Tignan mo sa Alice Bo, walang takot. Kahit magaling mati ko na sila sa hindi sasabihin nyo, mas may takot siya kung sino man ang tao.
Kasi hindi yun korte.
Exactly. Hindi din yung
Like,
correct.
it's for
Trial by
legislation purposes. Yeah.
True.
Pero wala namang legislation na mangyayari. Wala namang silang gagawin mo. It's for, yeah, it's for PR.
Kaya nga sabi nga, Alice Bo,
100%
hindi ako magsasalita dito pag sa korte na lang daw. Pero hindi pa rin nila inaano sa korte.
Never, hindi nila makontempt yung mga answer ni
Sila kasi, oo, kaya tapang nila, wala silang ano. Hanggang ganyan na lang yan.
For sure.
Oo. Tapos ngayon, ang nangyayari, dahil tinatagal na nila yung pag-interrogate, sila na ngayon yung nababash because of the how they interrogate, na hindi siya,
sobrang naawa
Bastos
yung
na,
mga
it's
tao.
rude.
Ay,
Ganun
alis
siya
ko,
yung-
bumalik ka. Kasi gano'n na siya. Diba? Huwag ka na lang magbastos para lang may public ka pa rin na pupunta sa ano.
di ba yung
Pero
questioning
magbastos
given nila,
naman.
so
Pwede
MU
na
kayo.
yun.
So may sexually ano kayo, yung mga line of questioning nila, hindi na maganda.
Tapos yung iba ka, kunwari nagagalit eh. Halata naman kunwari, that's not my question to you. Ang may atraso sa'yo si Alice ko, talaga galit na galit ka dun sa mga ano niya, building niya, talaga ba nagalit ka? O ilang corruption bang concern mo? Ba't ka nag-fake anger dyan?
Si
Tingnan mo.
Jane pwede, no? Yung mga pinakasal, bahala kayo. Hindi kasi nandyan si ano. tapos nasa yung cake ko, ganun din, hindi naman nila maano. Everything is publicity.
Kay Kibuloy, Senate din. O, pupunta na dito, galing US yung victim. O, dadalhin si Kibuloy dun, diba? Yun na yun. Pagdating dun ni Kibuloy, wala na yun. Wala na yun. Diba? Sobet tayo. Wala na talaga. Kasi, anonymous yung mga victim.
At saka, tignan mo, sinugod din ang KOJC. Eh, ang rumor nga is, they just wanna take over the land ng KOJC. Tapos tignan mo, napahit kasi meron daw po pinang heartbeat sa lupa. Nakangina, lumabas si Kibuloy. Sino na sa lupa? Narinig yung may heartbeat. Diba? Napayasin na. Kung yun sila, nasa bundok pala si Punyetang Kibuloy. Diba? Eh, ang pinaka-result, diba, just pinag-aawayan nila, pinag-aagawan nila yung, yung reward money. Pag nahuli pala si Kibuloy, ang laki pala.
14, 15.
Yun yung pinag-aagawan nila, parang aggressive na silang hanapin. No?
Mga constituents ata kasi, yung
So, bakit yung CIA, FBI, parang gano'n?
sa US kasi yung biktima, the only way that you can destroy a popular man is what?
Ang daras, no?
Yeah. Tarnish their name. By what? Wait. Common good. Buong mundo yun. Kaya nung sinabi sa akin, may narin. Okay, sige. Imbestigahan na si Kibuloy. Tuloy-tuloy na yan. Bakit hindi niyo sabihin yung mga narin niya dito? Ilabas niyo, pagsalitain niyo.
Yun, diba?
Parang na-judge siya ng tao. Pagsalitain niyo.
Meron,
Nakapiring
di ba nga yung unang in-interview ng mga babae?
Yeah, nakapiring siya. So, at asa nang meeting doon, may na-feel kang meeting. Napakadali nun. Ginawa nila yung kay Trump, diba? O ginawa din nila yun lately. Ang dami yung ginawa din sa States ngayon pa lang. Ngayon pa. So, sino ba yung actually kay PBB? Pero wala talagang lumalabas na. Madaming lahat yan. Pwede mo siyang i-ano ba yun? Michael Jackson. Sino ba ba? Ganun lang. Ganun mo siya kabilis. Because it's easy. Do something hard.
Eh, mapapagod yung mga tao, masyado na matagal yung expose.
Oh, alam mo kung bakit may retaliation yan. Malaking retaliation sa politiko na yan. Kasi they ride na dun sa dun sa popularity ng issue. So, ang retaliation sa kanila kasi malaki. Hindi nila naiintindihan, hindi sila nag-aano ng psychology ng public tsaka ng politics. Ang psychology niyan, kahit KOJC yan, apektado lahat, iglesia, ni Cristo. Kasi yung leader na yun, hindi nyo nirespeto yung nila. Buong KOJC yung humarang, walang sa nangyayari. Pilit nyo, nagkasakitan.
Walang warrant of arrest. Wala pa lang
Philippines is run by religion. And only by corrupt politicians. So saan kumakapit ang Pilipino? Sa religion. Hindi. Tinan mo pagdating ng election. Patay yan. Kasi nalinig yung Pilipino, hindi yan nagre-react. Sino ba naman yung parang, putang ina, ikulong si Kibuloy! May ganun ba? Wala. Wala, di ba?
Ang issue tuloy eh, kahit yung kay Sarah, bumaliktad na tuloy. Yun ang question sa kanya na bumalik siya na ngayon ng lahat. Kasi, it turned out na supposedly, parang party list ng mga teachers, pero lahat branded yung van niya kung artista man. Inano siya, in-scroll siya. Ang tagal-tagal kasi nilang ine-expose tong, ang tagal-tagal kasi nilang tinatelevize tong budget hearing supposedly. Pero ang nangyayari is, nagkakaipitan lang talaga ng budget. Nagkakaipitan ng budget. Okay lang na questionin mo, pero parang, I think masyado lang naging obvious to the point na hindi na nila pina-follow yung tradition ata sa Congress pag nagkaano na may mga ibang congressman na parang ganito, paulit-ulit tayo, ganyan. So bumaliktad tuloy sila ngayon ng masyadong exposed. Tapos ayan, nagpadala ng Duran, ang birthday.
Sino? Ano ito na Duran? Pwede na Marcos? Duran na banda? Oo. Ay, Duran? Yung 80s? Duran.
Pinapunta lang para birthday kasi niya. Yan. Nagkakasilitan ko rin. Kasi nga masyadong obvious. Kasi yung in-expose niya na dalawang tao lang yung control talaga ng budget. And Anyway, ginagawa lang naman ng dalawa sa iba silang balance. Actually.
Because they're both giants. Ganun
Exactly.
talaga.
So it's chaos.
Wala talagang
Ipitan silang lahat. Kanya-kanyang flex ko ng ano.
Ayaw!
Dun sa ano,
May dapat pa.
sa main house.
Nilajot.
Sa clinic pa.
Kala ka dun ako.
Ito talaga kung magkakasama na parang ganyan tayo. Pwede bang ano, palas tayo ng mga 12. May pasok bukas eh.
Ano oras na?
May dialysis bukas.
Ay, Tina, tapos na!
Yung klase ko, Tina.
Uy, si ano to ah. Ito yung pinakagwapo
Isip
na
ko na sa-
lalaki.